In 5 minutes. One, and we'll be starting today's workshop. It's Oncofertility workshop, and the theme is bridging the gap between oncology and fertility team, clinical pearls of wisdom. Now I'm very happy to conduct this workshop now consecutively third time, and we were discussing majority of the theoretical factors like how the cancer and cancer treatment it affects the fertility, and especially this comes into picture in the young cancer survivors and how we can improve the quality of life. But the main aim of today's workshop, what I want to achieve at the end of this, is we want to keep it more and more practical. Where I'll tell you the agenda of the session. I think, can I have the screen, please? Yeah. So the first, I'm going to discuss about the concept of the oncofertility. Nothing much theoretical, just a broad overview. And in that, I want to cover what current challenges we are facing in developing a proper ideal oncofertility setup. And once we understand the challenge, how collectively we can overcome those challenges and how we can formulate such a kind of the unit, and what are the key features of those kind of unit and practical difficulties. And at the end, we need to come to a practical solution, like how we can make it very much feasible, accessible, and affordable to our patients. Then we will just, my colleague Sangeeta, she is an embryologist, she will be discussing fertility preservation strategies in female and male. And then the most focused one would be our panel discussions, where our main focus is how combinedly we can approach such cases. So we will be discussing some case scenarios based on, one is the oncological point of view, then how the counseling will be done at oncological end, then how the patients will reach to our end, how the fertility team will make sure the different options available to them, how we give those patients again back to the oncology, and how they will again complete the circle of the fertility after curing when they come to us for the pregnancy. And we have our eminent panelist. I welcome you all. So Dr. Nikhil Kalyani, he is a consultant radiation oncologist at Jaslok Hospital and Research Center. And we have Dr. Bhausaheb Bagal, he is professor and consultant medical oncologist at Tata Memorial Center, Mumbai. And we have Dr. Sampada Desai, she's gynec oncologist at I think Hinduja Hospital now. Yeah. So I welcome all our eminent panelists. Thank you so much for joining us. And without wasting time, I would start with my first talk, just short one to give an overview about the concept of the oncofertility. Now, as we know that this is the era of increasing cancer survival rate. And as these young cancer survivors enter their reproductive years and contemplate pregnancy, it is very important to understand the impact of the cancer and its treatment on fertility and pregnancy outcome. So, a very strong predictor of emotional well-being is feeling healthy enough to be a good parent. So, different studies have shown parenthood can represent normalcy, happiness, and life fulfillment in the cancer survivors. So, as we know that nowadays there is a great shift of focus from survival only to the survival and quality of life. So, here our role comes in to this. Okay, so the importance of fertility preservation is receiving specialized counseling about reproductive loss and fertility preservation is associated with less regret and greater quality of life for cancer survivors. This have been proven in many studies. We have got the examples also. So at the end, I'll be telling you our real life scenario cases, what we have treated at our centers. So how the people were gone through the regret and then ultimately they have completed the family. So this is actually true, and that gives us the very important aspect of the fertility preservation. So there are different international organizations like Oncofertility Consortium, ASCO, then fertility organizations like ESHRE and ASRM. So they have demonstrated international standard of care is to provide clear and consistent information about the impact of cancer treatment on fertility and fertility preservation options where there is a curative intent. So it is very important to at least discuss these points to all the patients. And then comes what exactly is the oncofertility. So oncofertility is an umbrella term which includes care from both cancer as well as the fertility healthcare providers. So it's a combined approach, and it involves detailed discussion about the risk of fertility due to cancer and its treatment like chemotherapy, radiation, as well as the surgeries. Then what are the fertility preservation options available? And then the cancer treatment related complications, other complications like puberty delay, then menstrual problem, hormonal deficiencies, as well as sexual dysfunctions. So all these discussions include this oncofertility umbrella. And here at the same time, providing detailed information to the patients as well as to their spouses, families, that is there. And at the same time, providing the psychological support. So it is not just one or two persons or not just fertility and oncology. It includes all, even the psychologist and then the counselors. So it is basically, it's a complete team which deals with all this. So oncofertility was just an idea 15 years ago. And today it is a distinct field of medicine offering new hope to cancer patients who will survive their disease with options for preserving their fertility that prior generations lacked. So basically, what are the key components of the oncofertility care? So most important is what, as I discussed, the information, right information to be provided. So it's the information provision. At the same time, age appropriate communication, because we will be dealing with especially the young patients, young adolescents, sometimes pediatric population. So age appropriate communication is very, very important. And so that's why there is a role of the psychologists, counselors, and even the mental health professional into this. At the same time, as I mentioned, psychological support, and at the same time the financial support, because it is not just theoretically we are discussing. We need to tell them how practically it is possible and how we can support them while they are going through this cancer treatment, as well as at the simultaneously whether these options to be considered. So what are the challenges in this fertility preservation decision making? And these challenges are important because actually these are the points which we have to consider, and we have to analyze each and every point to give the better units for these patients. So basically we need to give, there are multiple sources of information available. So like from the doctors, from the family, society, social media. So basically we need to give them a proper information. So any decision making, to make it very clear, we need to give the proper information first. So for that, one is proper information from the doctors. It can be in the form of the visuals, audio visuals. At the same time, a proper information booklets that we prefer, because then there will be detailed information, and it is not easy for them so to understand that information at one go. So obviously we need to give the proper timeline for them. It is, we can't expect them to immediately react on those and immediately give the decision. So it is like they should take little time to understand and then decide upon it. At the same time, it is very, very emotional crisis, because there is a cancer diagnosis. They don't have much time. One is, of course, they have the there is an existential crisis. They don't know, or uncertainty about the survival and what would be the future. And at that point, they have to think about whether they will think of the fertility later on. So that is very complex state of mind. That's why we require a psychological support at this time. And at the same time, because we have a very tight time frame to make the decisions, because there is a hurry in giving the cancer treatment. So we don't want to waste time either. So that's why it is very critical time frame. And at the same time, for the patient, it is important to understand the reproductive function. So that means it is more in the young and adolescent age group. So first they need to understand the reproductive biology, then their future desire for the fertility. And at the same time, important things are issues of geographic access to the care. So we should be knowing, especially where the centers are available. Is it nearby? How accessible it is? How feasible it is? And at the same time, how affordable it is. Because financial constraints, it is quite a lot. They have to undergo too many, multiple cycles of whatever surgeries, chemos, radio. There is a long treatment. We don't know about the whatever prognosis. At the same time, they might have to spend here. So we will come to it, like how feasible it is and costings of it. But yes, these are the challenges where we need to sort it out. And this I'll come to it. So basically we need to formulate certain units where we require a one critical point of contact, which many of the international organizations have suggested, something called as a patient navigator. So this is sort of the coordinator, that person who will be constantly in touch with the fertility team, clinical care, that is oncology team, and even that has a easy, accessibility for the patient also. And that person to coordinate so that to avoid the any delay. And there should be a reliable, sensitive person and who should respond very rapidly and empathetically. So that is important. So basically this is in our hand to formulate like how we can combinedly work, and different how we can formulate such a kind of probably one center or whatever, one group of the people who are working like this, like a helpline, and we are helping them out, and those people are navigating the patients to the different teams. So somehow we need to do that. So basically in certain countries like even Canada and all, it is very much actively done. So it is like we have to take an initiative to formulate the guidelines, basically, like how we'll be doing it and how we can regularize it, basically. So there are certain guidelines for the counseling of these families. So that is more of a at oncological end also. At the same time, it is from the fertility end also. But the first set, this is like a at the oncological point of view, when they will be at the time of the diagnosis. So and when they have to first discuss about the fertility preservation. So basically we have to set it is a sort of private discussion. We have to set the environment, and we can't assume that they will be knowing already the things. So we need to start from explaining the reproductive biology, then give themselves give the time for processing the information. So we have to provide the right information, especially some written material where they can little bit think and then take the decision. At the same time, in the adolescent age group, it is not like just parents can take decision on behalf of the kids. We should take a help of the pediatric counselors, and even children should be actively involved, and age appropriate communication has to be done, and there are different tools available for it. So we need to make use of that. So basically our aim is to formulate such a kind of the clinical pathway for the oncofertility care. So it is at the first, like oncology team, when there is a first diagnosis and there is a need for these kind of the oncofertility services, then that first documentation has to be done. What is the risk to the fertility, and what kind of counseling is been done, and what options have been given. So this is the documentation at the oncological end. And then this coordinator, it will go to the coordinator who is coordinating, and then immediately they will direct that patient to the fertility team. So here basically right now we don't have these, this is the missing part. We have the oncological team which are working at their end. We have our fertility units which are working at our end. And then sometimes as a doctor's consultant level, we coordinate with each other. But still, it may not be possible in the busy units every time a doctor's coordinating. So we require such a kind of the middle navigator. So it can be like with whatever 24 hours helpline or something we have to formulate, where immediately at the diagnosis, these people will decide, once the consultant from the oncological side has given okay, these patients have received the counseling, and immediately they have to direct to the fertility team, and the necessary things will be done, necessary procedures would be done. And at the same time we will be I'll come to that, like what we need to know at the time of the referral. And once the completely that preservation has been done, and again it is very important for that patient to go back to the oncology for the further treatment without any delay. So that is also very important. So the role of this coordinator will be important, and we need to formulate that. So this I was talking about, like handover from oncology to fertility team. So what exactly we need to know is the brief history. What is the diagnosis, then developmental maturity of the patient, then plan treatment, what is the plan of the treatment, and urgency. That is very important. So how much time we have is this, especially for the female patients, because we need to do the ovarian stimulations in them. What is the prognosis? And then obviously the handover of the patient and family's understanding of the diagnosis. Then what are the initial, at the initial consultation, what are the options given for the fertility preservation, and what was opted by the patient, what any other procedures planned, is there a need for the menstrual suppression, and other factors like pertinent to the cancer and reproductive potential, like what is the likelihood of the radiotherapy relapse, then factors that may specifically increase the surgical risk, like mediastinal mass, if there's a battle scar abdomen, or significant immunosuppression is there, bleeding disorders, and presence of a malignant abdominal or retroperitoneal mass. So that also we need to know. And social concerns of the family, like any custody issue or parental disagreement, in especially cases of the pediatric and the adolescent age group. So basically these are the things which are required at the time. So definitely, this is the picture of our center where we have all these facilities. So we require all this. I mean, a high-tech embryological lab. We should be having workstation. Then these are the incubators. Then cryopreservation units. So all that will be covered by Sangeeta in the strategies. But this is like, I mean, it's rightly said that nature nurtures for 9 months, but science struggles for mere 5 days. So it's very meticulously we can do it, and then we can preserve these gametes for years together, so to give them later on the happiness. So but currently what we are facing, what is coming in between, is these three kind of things. So currently we are having information gap, we are having data gap, and we are having option gap. So very less people are having the information about it, awareness. So we are trying to do it, conducting these workshops again and again, making this awareness. More or less the things are same, but we just have to repetitively discuss it to have the good emphasis, so that we are giving the right information. At the same time, right data is available, because when we are doing more and more cases, we need to store the data, we need to contribute in the research, so that the similar data can be used, and then we can make a contribution in the research. At the same time, option gap. So these different options, from just what you can say, oocyte preservation, semen preservation, embryo, to the tissue preservations, they are available. So that has to be known by the clinician as well as the patients, and then really we can make a difference. So always, and the last time also I had said, so it's really a time to merge. We should have a specific entity as a oncofertility combinedly, and there is a need to formulate certain guidelines and work accordingly. And so definitely we can form a good oncofertility program, where we have to have, there are certain what you can say, goals for this. So it is like, we have to, what would be the goals, like to provide timely and comprehensive fertility risk and preservation consultation. So it is important timely at any time. So it should be like 24/7 available services, offer patients to a range of appropriate treatments. So it should be all ranges of the treatments available, inclusive of the treatments which are experimental, like tissue preservation. So to serve as a resource for patient and healthcare providers who are seeking up-to-date fertility preservation information. And then offer, at the same time, we should be offering genetic counseling for genetic cancer risk assessment in the relevant group of the people, and offer other necessary reproductive health services like contraception, sexual health, menopausal management, because of course it leads to premature ovarian failures and all. So just to summarize, all patients and families have the right to know if their fertility is at risk, even if there is no time to do anything about it. So at least a word to a patient is important. Even if there is no time to do anything, or there is nothing that can be done, or prognosis is poor, we do not think it is a good idea or necessary to preserve a fertility, still it has to be discussed as per all the guidelines. And when it is judged to be medically safe by all relevant means, with our information and support, the decision then rests with the patient and family. But we have to document that discussion was made, and then what was the decision at the end of the discussion, and then the written resources to be provided. So that this is very important as far as the fertility preservation, I mean oncofertility guidelines or preservation is considered. So that basically at the end, what I wanted to conclude is, we need to formulate these kind of the guidelines and formulate one referral pathway which is very easy for our patients. So I would call Sangeeta for next thing, because already the time is, I think it's moving fast. So I'll call her for next topic is fertility preservation strategies. And then later on, we'll go to our panel discussion. Thank you.
Hi, good afternoon, one and all. So today I'm going to brush up on just what, when, why, where, and who, and how fertility preservation in cancer patient, mainly focusing on the embryological aspects. So, as in continuation with Dr. Snehal's slide, so we all know that the survival rate has already improved. So, with nowadays increase in the reproductive age group and the childhood cancer increasing, at the same time, the survival rate is also increasing. So, that is because of the early detection with the sophisticated diagnosis and treatment modalities, the survival rate has improved. So we are now focusing on not just the survival, it's the survival and the quality of life. So we know that the cancer and the cancer treatment has a deleterious effect on the reproductive health. So the long-term side effect are premature gonadal failure, that is infertility. In male, it can impair spermatogenesis and has a negative impact on the semen parameters. It can result in transient oligospermia, transient azoospermia, or it can cause a irreversible azoospermia. Whereas in female, it can lead to amenorrhea, anovulation, atresia, or poor quality eggs, resulting in a negative impact on the fertilization and implantation. So before the cancer treatment, it is important to estimate the risk of fertility. So pre-treatment factors includes reproductive and obstetric history, history of sexual transmitted diseases, history of surgery or trauma to reproductive organs, family history of infertility, and underlying medical condition that could result in infertility. So following this hormonal evaluation like AMH, FSH, LH, estradiol in case of women, in case of men, testosterone, and inhibin B level should be done to assess the fertility function. Fertility risk assessment tool is nowadays available online to generate an individualized risk assessment based on the age, cancer diagnosis, treatment, and fertility and future fertility goals. Gonadotoxic risks can be stratified into 4 categories. Either it can be no risk, low risk, intermediate risk, or high risk. So according to the European Society of Medical Oncology, they have recommended the following. All patients of the reproductive age group should have a complete oncofertility counseling as early as possible, that is even before the treatment is being planned. And the counseling should be individualized. During the counseling, the medical health professional and the genetic counselor should be available. Written information or the online resources should be provided to the patient. Those patients who have the potential interest in fertility preservation should be referred immediately to the fertility specialist team. And since there is no threshold of the toxicity, every patient should be considered as that they are at a potential risk of developing treatment-related gonadotoxicity. So what is fertility preservation? So here we tend to protect the gamete, the egg or the sperm or the embryo or the tissue so that the person can use them to have their own biological children in future. So this is our unit where the treating center should have well-equipped and also with a highly specialized team consisting of oncologist, gynecologist, reproductive biologist, transplantation surgeon, and research scientist. So we should have a cryopreservation unit. This is the laminar airflow where we tend to screen the oocytes. And the oocytes are cultured in the incubators for almost 5 days. And we have the micromanipulator to do IVF and the ICSI procedure, and laser-assisted hatching and pregenital for embryo biopsy for PGT. So fertility preservation strategies may not be suitable for all. So the success rate of a fertility preservation option depends on the patient age, health condition, that is the type and the spread of disease, type and the dosage of cancer treatment, time available, and whether she has a partner. Fertility preservation in female, the established ones are the gonadal shielding, ovarian transposition, oocyte cryopreservation, embryo cryopreservation, ovarian tissue cryopreservation. The investigational are GnRH analog, in vitro activation, in vitro maturation, and transplantation. Whereas in males, established ones are gonadal shielding, gonadal transposition, semen or sperm cryopreservation. In investigational, we have GnRH analog or testicular tissue or spermatogonial stem cell cryopreservation. So we will look into the fertility preservation strategies in female, where the first thing is gonadal shielding. It's done in mostly in the radiation therapy to reduce the dose of radiation delivered to the reproductive organ. But the limitation are possible with selected radiation field and anatomy. Experts are required to ensure shielding does not increase dose delivered to the reproductive organs, and gonadal shielding cannot be used in the combination therapies. Ovarian transposition. Ovaries are, in this case, mobilized from the field of radiation to protect the ovarian function. The latest one is the laparoscopic modification, where the ovaries are temporarily affixed to the anterior abdominal wall. But the only disadvantage of this is due to the stretching of the ovaries, the fallopian tube might get damaged. In that case, the option natural is not possible. Natural conception is not possible. They have to go for a IVF treatment. But in this ovarian transposition, pregnancies have been achieved even without surgical repositioning. So egg cryopreservation. So this is recommended for unmarried and those patients who do not have partner, or in the patient who have ethical or religious objections to embryo storage. So it's highly recommended that they have a fair chance of good ovarian reserve, and the medical condition allows controlled ovarian stimulation and oocyte retrieval. So in egg cryopreservation, what we do is we tend to stimulate the ovaries. Once the follicles are of appropriate size, the egg retrieval is done and they are frozen. It looks simple, but it's not the same, because oocyte cryopreservation is technically challenging because of two reasons. One, we tend to get a different cohort of oocytes. That is, we tend to get a mature oocyte and the immature one. Mature is the metaphase 2 stage oocytes, whereas the immature ones are GV and metaphase 1 oocytes. And the second challenging thing is the oocytes has a large cytoplasm, unlike the embryos and the sperm. So the water content is more. So during freezing, the cryo injury is more because of the ice crystal formation. And also the drawback in oocyte freezing is in M2 stage, there is an extremely sensitive they are extremely sensitive to temperature, and presence of the mitotic spindle, zona hardening occurs, and there is a premature release of cortical granules. Whereas in GV stage, since there is no spindle fiber, chromosomes are protected within the nuclear membrane, but still the survival and the maturation rate is much lower. Embryo cryopreservation. This is a very established technique which has a very good success rate, and patients who have partner and have the time to delay the therapy can go for embryo cryopreservation. Here again, the follicles are stimulated, the oocytes are retrieved once we get an appropriate size of the follicle, and this is followed by either IVF, in vitro fertilization, or ICSI, intracytoplasmic sperm injection. Here, we tend to inject the sperm directly into the egg. So once this is done, the next day. So basically 5 days, the embryos will be cultured in the incubator. So the day 0, we do ICSI, and day 1, we check for the fertilization. And day 2, it should progress to either 2-cell stage or 4-cell stage. On day 3, it's anywhere between 6 to 8-cell stage. And day 4, it's morula, and day 5 is the blastocyst. So embryo freezing can be done either on day 3, that is on 6 to 8-cell stage, or it can be done in day 5 blastocyst. So we generally prefer a day 3 freezing rather than day 5. The reason is In day 3 freezing, we can have multiple attempts, whereas in day 5, there is a limited number of attempts. And also, in case those patients who have a familial history of genetic disorder who wanted to do PGD testing. So in that case, blastocyst is preferred because we get more number of cells for embryo biopsy and we can send it for testing. Pre-implantation genetic testing. Again, the embryo biopsy can be done in a day 3 stage embryo or in blastocyst. But we prefer to do it in blastocyst because we get more number of cells, and even the genetic lab prefers to have more number of cells rather than 2 cells. And also there is an increase in case of day 3, we tend to biopsy only 2 cells. So very less number of cells, and there are also high chances of mosaicism. And once the biopsy is done, we tube them and send it for genetic testing. So usually PGT is done to allow the detection of cancer genes, especially BRCA1, BRCA2, in case of familial adenomatous polyposis. So in these cases, we tend to do PGT, and only those which are euploid or normal embryos are transferred. Basically, freezing itself can have a deleterious effect on the oocyte, embryo, or sperm. That's because of 2 reasons. One, there can be ice crystal formation. That's cause the cryo injury. Usually the cells can undergo physical, mechanical, chemical, or osmotic stress. So that's the reason we tend to add this cryoprotectant, which are nothing but the permeating and the non-permeating agents. So that helps in dehydrating the cell and also to lower the freezing point of the cells. So main method which we follow is vitrification in case of egg and the embryo freezing. But whereas rapid freezing, we use it for the sperm. Slow freezing, we do not go ahead. That's only reason is we need a sophisticated chamber for it, and it takes a very long time for the freezing to happen. And the device usually which we prefer is, in case of sperm, we use the straws or the cryovial, whereas in case of embryos, we use a cryolox or cryotip. So usually we go for a vitrification where the oocytes are subjected to different concentration, a higher molar concentration of solutes, and then they are plunged into the liquid nitrogen, which is almost minus 196 degrees. And once, in case later, if we want to retrieve them, they are thawed back. They are subjected to thawing solution, diluting solution, and wash solution, and then they are transferred. Ovarian tissue cryopreservation. This is an option for prepubertal girls. The extraction, we require very less, half the ovary may be sufficient, that is 20 to 30%. Here, once the ovary is retrieved, the corticals are dissected and they have made into very thin strip, probably not more than 2 millimeter. And they are taken in a steel rod kind of thing, and they are placed and plunged into the liquid nitrogen. And later, whenever we require, we are thawed them with different medias and they are transplanted. Or another option is we can go for in vitro maturation, but the success rate is much lower. So they prefer transplantation. Now, ovarian tissue cryopreservation has come under it's not the experimental label now. So it is an established protocol. The reason is almost we have got 130 live births have been reported in 2017, and the success rate of the live birth is almost 20 to 30%. And in each case, the hormonal production has also been restored for up to 12 years, that is average of 2 to 5 years. And there is one study which has reported that in 18 patients where they had been frozen, between 9 to 20 years, girls have those tissues have been cryopreserved and auto-transplanted later, have resulted in 10 live births for almost 9 mothers. So ovarian tissue cryopreservation should be carried in centers where there is a clinical expertise with IRB approved protocols that includes a follow-up for recurrent cancer and in patients with increased risk of infertility. And the success rate depends on careful selection of the patients, surgical expertise, and laboratory facilities. The advantage of OTC is we need not delay the cancer treatment. It avoid the risk of ovarian stimulation, no need of partner or the donor sperm, preserve larger pool of follicles and allow for the resumption of ovarian follicles. Ovarian function resumes between 6 to 240 days post-transplant and lasts up to 7 years, and the only technique available for prepubertal girls. The limitation is possibility of reseeding of cancer cells, resulting in cancer recurrence. So this is the result of ART in the fertility preservation. This is a almost recent study from Fertility Sterility 2017, where they have showed with embryo cryopreservation, the live birth rate per ET is almost ranging between 22%, here 45%, whereas oocyte vitrification, though not in the cancer patients, the live birth rate is pretty good, that is 22 to 50%. And ovarian tissue cryopreservation, which was done in almost 111 cases, 32 patients have conceived with 29% live birth rate per patient. So moving on to the experimental or the investigational procedures, GnRH analog. So this is used in prepubertal girls. Here there is a suppression of gonadotrophin levels and this GnRH decrease the ovarian perfusion, but there are still insufficient evidences to support the same. But if GnRH administration has to be started, it should begin at least 10 days prior to chemotherapy because of the initial flare-up effect, and should continue till 2 weeks after the end of the chemotherapy. And in case of estrogen-sensitive tumors, tamoxifen therapy can be initiated after the GnRH analog treatment. Autotransplantation, this is one of the successful treatment. After ovarian tissue cryopreservation, those tissues can be transplanted back. So it is either by orthotrophic autotransplantation or heterotrophic autotransplantation. Both the technique had given a successful pregnancy. In vitro maturation, where in those cohort we get immature eggs, they are subject to IVM, in vitro maturation media, which has gonadotrophins, nutrients, proteins, and growth factor. So we culture them almost for 2 days, almost 36 hours, and then we tend to check them whether it has progressed to metaphase 2 stage. Only then we can go ahead with the fertility treatment. So, but the implantation rate of IVM are low, between 10 to 15%. This is relatively newer technique. This is the in vitro follicular activation, but this concept has been carried out in patients with premature ovarian insufficiency. Here, the concept states that the primordial follicle, which is of a larger population and mostly quiescent, they are activated. Every cycle they get activated, a few undergo the selection, and only one dominant follicle progresses. This is because of the balance between the AKT signaling pathway and the hyposignaling pathway. But if there is a disruption in the hyposignaling pathway, they show that there is an activation of the primordial follicle. So what they have done is ovarian tissues were removed and fragmented. This fragmentation has caused disruption to the hyposignaling pathway. So in turn, it has activated the AKT signaling. So, and also they have subjected them in IVA, in vitro activation media, which containing phosphatase, antensin homolog and inhibitors and PI3K stimulators. And they have seen there is a promotion, the growth of the primordial follicle has gone to preantral follicle. So this study has been done in premature ovarian insufficiency, and live birth has also been resulted. So this can actually be extrapolated into the cancer patient also, and those patients where the elderly patients who require their own biological kit, or in those patients, pubertal females where we had frozen the ovarian tissues. Moving on to the fertility preservation strategy in male. So one which is the gonadal shielding. So there is a physical gonadal shielding and chemical gonadal shielding, but chemical one is still in the experimental thing. Physical gonadal shielding, this is used to minimize the scatter radiation to the testis in both adult and children. The sperm cryopreservation, this is the most effective and efficient method. This is recommended before initiation of the cancer treatment, especially in the post-pubertal and adult males. Before cryopreservation, all men has to undergo infection screening and semen analysis. And usually we recommend 1 to 3 samples with a gap of 3 to 4 days of abstinence. Surgical sperm retrieval techniques. So in case of difficulty in sample procurement or in severe oligospermia or azoospermia, there are 2 options. One is epididymal aspiration or the testicular aspiration. So it can be testicular extraction, or micro-TSA can also be done. In case of testicular tissue, we tend to, there will be, the biopsy tissues are usually handed over. We subject them into the culture media, and all these seminiferous tubules are teased, and the sperms are released, and the sperms are then centrifuged and frozen in multiple vials. The success rate with the thawed sperm, usually in case if they later want to undergo IUI, fresh semen is better in IUI procedure rather than the frozen thawed semen IUI. But whereas for IVF ICSI, there is no difference in the fertilization and the pregnancy rate between the fresh and the frozen thawed semen sample. Fertility preservation strategies in prepubertal boys. This is the testicular tissue cryopreservation. Again, this is the experimental one where live birth rate has not been achieved till date. Here, testicular tissue cryopreservation is the only option for prepubertal male. Even neonatal testicular tissue possesses the spermatogonial stem cells. So either they can be frozen as a cell suspension or as a testicular tissue. So in males, the recommended option is the sperm cryopreservation. So regarding the documentation and storage, usually all the samples are labeled, and we have a return as well as a computerized inventory system. And since all sperm, egg, and embryos, once they have been in the frozen state, they are in the dormant state. So we can preserve them for decades, but the Indian guidelines doesn't allow that. So, but they haven't at the same time not mentioned like how long or how long duration we can preserve them. But the statutory maximum time period for storage for medical reason is 55 years in case of male and 50 years for female. Every year renewal in terms of payment as maintenance cost, which is valid for 1 year. Legal and ethical issues. So the concern form should have a provision for disposition of the frozen samples in the event of death. So either it can be discarded or use of concern to use it to the partners or third party donation. In case of minor or prepubertal fertility preservation, parental consent and assent should be taken. Collection of the semen should be counseled before. Legal control at the time of maturity has to be mentioned. And they all should be tested for communicable disease. Testing should be done. And discard consent policies should also be there in long-term freezing. When the client no longer desires to use the stored embryo or donor relinquish rights to specimen that are donated, provision for discard of specimen in case of non-payment of storage fees. So these all things should be addressed in the consent form. Lastly, restoration. Once they have preserved all the gametes and later once they want to restore the fertility, they can, in case of embryo freezing, they can undergo embryo transfer. In case of oocyte freezing, ICSI followed by the embryo transfer. In case of ovarian tissue cryopreservation, either it can be natural with in vitro follicular activation, or they can go for autotransplantation again, followed by IVF and ICSI. In vitro maturation can also be done, but again, the rate of the success rate is almost less. But during the cancer treatment, it's all the patient should be counseled of the contraception, and it was also recommended to continue the contraception 3 to 6 months post cancer treatment, and before starting on the fertility treatment or when they plan for pregnancy, they have to be assessed for fertility function, mainly the gonadal markers. And this is the same with males also. The recommended waiting period is 9 to 12 months, but even after that, it doesn't guarantee that there would be sperm production. But before going on planning for pregnancy or for any ART treatments, semen analysis and sperm DNA fragmentation should be done. To summarize, cancer may have a negative effect on male and female reproductive health through multiple pathophysiological mechanisms. Radiation and chemotherapy exhibits dose-dependent gonadotoxicity. Fertility preservation should be discussed with all patients of childhood stage or the reproductive age group. Rising pregnancy rate of sperm cryopreservation, oocyte cryopreservation, live birth after transplantation of human ovarian tissue have shown a promising future in the field of fertility preservation. Adjuvant procedures should be employed when appropriate. Innovative and possibly revolutionary technologies for fertility preservation are currently in development. Once established, may change our current approaches to fertility preservation in cancer patients forever. Thank you. So I think without any delay, we will start on with the panel discussion. I call upon Dr. Snehal to start the same.
Thank you, Sangeeta. So we will start our panel discussion. Just a second. Okay. So here we'll be putting one case scenario, and we will see like how we'll complete. First we'll have our oncologist view, then we will see like how we deal. There are different options of the fertility preservations, and how again they will go back to the oncologist, and again they'll come back for the pregnancy. So this discussion will be based on cases, different scenarios, counseling, then options for fertility preservation, referral pathways, and ethical challenges. Okay, so I think we'll start with Sangeeta will read out the case scenarios, then we'll put a different viewpoints. So everyone, we will discuss about it, and then at the end we'll formulate the final summary on it. Yeah.
The first clinical scenario. The patient details are 27-year-old unmarried women, asymptomatic, diagnosed with CIN3 on routine pap smear. The cancer diagnosis is adenocarcinoma stage 1B1.
Okay, so
the viewpoint is in cervical cancer, what are the possible causes of fertility loss?
So I think ma'am can start with.
Since she's 1B1, the treatment for her is, the standard treatment is radical hysterectomy, VPLND or radical RT. Okay, since she's unmarried, if she has a desire to fertility preservation options can be given to her. The first option is radical trachelectomy with in which only the cervix will be removed and rest of the uterus and the ovaries will be preserved along with BPLND. The other options for her is radical hysterectomy, and the ovaries can be preserved.
Yes. Okay. And then before like radical hysterectomy, how much time generally we will get? So can we go ahead with the like she's unmarried, so oocyte cryopreservation. So can we go for the stimulations?
Yes, I think you can wait for that much time for oocyte cryopreservation.
Yes, so at least for 2 weeks time,
Yes.
because generally we require 2 weeks time, like 8 to 10 days time for the stimulation and the egg collection, oocyte retrieval. And she is young, so generally we will have the good reserve. Of course, pre assessment we will be doing ovarian reserve testings like AMH and AFC. With that, if we get around 15 to 20 eggs at one cycle, so that definitely that will be good. And if at all we need to start give one more stimulation, it can be successive. So maximum to maximum it can be like 4 weeks time. So I think that much we can take in these kind of patients, right? So I think any other points are for if later on, suppose in the advanced stages, if the radiation or something, sometimes we need to give the radiation in such a patients.
For radiation, issue is that for ovarian function preservation, you can do ovarian transplantation.
Yes, so at that,
so
yeah.
the only thing is you need to consult a radiation oncologist where to transfer. Because we need to know where is the portal, where are the radiation doses,
Yes.
and then transfer. Sometimes what happens, we have seen the cases where ovaries have been transferred to the lateral pelvic wall, which doesn't make any sense. Because what we treat is the full arc or a box field or force field, then it's going to be in a portal.
Okay.
The function may not be preserved. Second issue is after a pelvic radiation, even the normal pregnancy becomes a problem.
Yes.
Even if you preserve a ova and you transplant embryo into the uterus,
Yes.
that uterus may not carry till the 9 months.
Correct.
Because there is a lot of fibrosis, the endometrium is not stimulated even with the hormones. So that is also an issue in a radiated pelvis.
Correct, sir.
So if the patient is desired for a fertility preservation, then better is to go for a oncologically safe fertility preserving surgery rather than going for a radiation.
Correct. Yes, sir. So yeah, in that was rightly said, because it has the thin endometrium issues as well as the miscarriages, then preterm and everything. I mean, then later on, certain these patients require a gestational carrier, that is the surrogacy. So nowadays, as you must be aware, like now ART Act has been started. It was initially guideline. Now this December 2021, it was ART Act, and with that now there is only a altruistic surrogacy. So we can't go ahead with the commercial surrogacy. And so it is again very difficult for the patients, that someone known relative only carrying the pregnancy without any remunerations and all. So it has become again very difficult. So yes, these things to be first initially discussed, like what would be her options of the fertility accordingly. And yes, so here definitely these possible causes of the fertility loss can be chemotherapy, radiation, or surgery. And as madam has already said about the fertility sparing surgery, that is radical trachelectomy is the better option, and then she can go for the childbearing later on. And what are the options? Yes, so these are the different options, because she is unmarried. So mainly we will consider the oocyte cryopreservation. So only thing, just to mention here a few things. So the cervical tumors, when it is larger than 2 centimeter, of course there's an increased risk of the lymph node involvement, and the cervical margins must be free of neoplasia to perform fertility sparing surgeries. And until the stage 1B1, it is possible to perform radical laparoscopic trachelectomy with lymphadenectomy. And if the cancer has spread to the tissues next to the uterus, then whatever radiation or chemotherapy is recommended. But as we know that we need to think it twice before going for the radiation in such a patients, considering her future fertility. And definitely this is the options like oocyte, embryo, or ovarian tissue cryopreservations and transposition. And if suppose the radiation in any case, then we need to think about the surrogacy or even the uterus transplant. But again, uterus transplant is also investigational, I mean experimental. It is not yet a routine therapy. So yes, so basically in such a patients, so it is again a team approach for these things, and to decide what kind of according to the disease and what kind of the therapy we can give to such a patients. Then we'll move on to the next scenario. I think on
The second clinical scenario, the patient details are 15-year-old post-menarcheal girl. The cancer diagnosis is scleronodular Hodgkin's disease, stage 2 BB.
So, sir, I think you can discuss about like how severe would be the risk of damage to the fertility potential in such a cases.
Yeah. So whenever we are faced with such situation, this is a common situation, Hodgkin disease or other lymphomas or diseases of young people, and where fertility preservation is important. So whenever we are faced with such situation, first of all, we determine their disease characteristic and figure out what is their prognosis from disease point of view. And as you all of know that Hodgkin disease has a very good long-term outcome, and fertility has to be given due consideration.
Yes.
Now next is the risk of infertility associated with the current available treatment options. So treatment of Hodgkin disease has radically changed over last 2 to 3 decades. And whatever data we have about infertility, it is lagging roughly a decade. So the current infertility outcomes described are with the treatment which was given in the maybe 2000 to 2010 period. So definitely that is not applicable, but the risk is we have a rough idea how it is. Definitely looking at her stage, so she becomes stage 2B, is typical intermediate risk disease. And we have 2 options for this patient. One is to treat her with combined modality treatment with abbreviated chemotherapy and abbreviated radiation. Most of the time, the disease would be in the mediastinum, and you have issues with radiation to heart and lungs and breast, etc. You want to avoid that. And you might want to use chemotherapy only approach. But when you do such chemotherapy only approach, you tend to give more cycles, and cumulative doses of drug tend to be definitely higher. So here you are trending towards more chemotherapy, and you are going to increase the risk of infertility in her case.
Yes.
If you use combined modality treatment, you are increasing the risk of local complication probably in the chest, etc. So you have to factor into. Most of the time, these people with the current ABOD regimen have very little or no risk of infertility, provided they don't fail. So roughly 15-20% of these people will fail this treatment. They require salvage and subsequent transplant. And in that case, the fertility is definitely compromised. So you have to make them aware about this risk with different treatment options and choose. And all such patients, we send them for counseling. And in certain situation where you require escalated chemotherapy approaches, we tend to counsel them for preservation options.
Yes, sir. So mainly, generally here also, do we get that time of 2 to 3 weeks usually?
Yes, so Hodgkin disease is
yes.
very indolent disease. You definitely can
get that time. Okay. Yeah. So here, as because she is a post-menarcheal, so then we still have an option of the oocyte cryopreservation, or again ovarian tissue cryopreservation. But because as that is the thing that tissue cryopreservations generally, those are under IRB protocol. It requires IRB protocol. So that's why, so oocyte cryopreservations would be preferred. And as we know that 2 to 3 weeks time will be there. But generally, sometimes here in the hematological malignancies, even because of the extreme catabolic state and all, ovarian reserve markers can be low from the beginning. Actually, that is one of the very practical problem with us. If the AMH or the antral follicle count is less, then definitely the retrieval at one setting would be less. And as we know that, as Sangeeta had said, because oocyte has a larger water content, when the thawing rate of the oocyte is little less as compared to the embryos. So definitely we would like to get the more like oocytes, like 15 to 20 at least, to get the good chance later on. So definitely both the options can be considered, but because she is 15 years, so here most importantly it is involving the parents, the consent of the child as well as the parent. Both of them should understand. And because here one more thing is to discuss about the transvaginal approach for the oocyte retrieval as well as the monitoring. So we may not, it may not be acceptable, so that we need to discuss these things about the patients. And other approaches like abdominal, perurethral or transvesical approach or the laparoscopic approach can be considered in these patients. Fine. So we'll move on to the next scenario. So basically this is the open-ended question.
What are the challenges in dealing with the pediatric cancer population?
So I think Nikhil sir also can comment on this, because you also comment so many pediatric populations and also hematological. So I think we'll take a viewpoint from all of you, because everyone deals with that.
For
So
pediatric patients, the main problem is for a Wilms tumor and your RMS, and especially in the pelvic RMS, the ovarian and the paratesticular RMS, in which we again radiate the pelvis.
yes.
The issue is not with any other radiation in the head, neck, or a chest area, because the ovaries or a testis will receive very scattered dose of radiation that may not be significant to cause the infertility.
Yes.
The issue is only with pelvic malignancies or a pelvic or a abdominal radiation,
Yes.
which can cause the issues of infertility.
Mm-hmm.
The main issue is the chemotherapy, because this child needs a lot of chemotherapy, and that.
Yeah, chemo long term. And
Yeah. So definitely most of these malignancies are highly curable with and most of them require very intense chemotherapy, and mainly alkylators and anthracyclines are routine use. So definitely, depending upon the protocol, their infertility risk probably is on the higher side. I think we have issues in terms of our ability to, because most of them would be pre-pubertal, so we'll not be
yes,
able to retry.
understand.
And I think the available options seems to be experimental as of now. So that's another issue. I mean, definitely this is an issue. And second thing is you have to counsel and deal with parents rather than the patient. So
Yes.
these are the certain issues.
More
But
issues. Yes. Ma'am, anything you would like to comment on this?
Mainly counseling them, and
Yes.
especially in female patient, most of the like ovarian tissue cryopreservation
Yes,
is still
that is the only option available. Yeah. So yes, main
The
yes.
other
Sir.
issue is to counsel the patients also, parents also,
Mhm.
because we are talking about 3-4-year-old girl,
Yes.
and you are talking about the fertility preservation for them in
Definitely,
the
it
parents.
becomes very
It
difficult.
becomes very challenging to
Hmm.
make them understand why we are talking and what we are talking.
Exactly. So that is really very challenging. And I think for that, we require a specialized team, specialized counselors, and that to the mental health specialists and related to this subject, and as well as the child psychologist also. Because as they say, as far as possible, involve patient, but in such a population, it is not possible to tell the child. And then it is very difficult that parents are taking decision on behalf of their children for their future generations. I mean, it becomes really very challenging. And that's what. So that is one. And available options we have, as you rightly said, these are all experimental. So we require those settings like institution review board, from the approval from the board, and accordingly go for. And definitely it is a difficult situation in front of them, and this gives the ethical concerns also. And important is about here, importance of the documentation remains, that is informed consents from the parents. So that is also very it should be very clear and accurate information, and about the storage, where it will be done, what is the cost, and what will be done with the tissue if the child doesn't survive. So it is very important to have these kind of documentations in the consent. Then who has the right to access these tissues, and for what purpose? And of course, this is also one very important point, that fertility preservation does not mean a guarantee that child will have a fertility in adulthood. That is also very important, as we are preserving both the things. Either if we, even if we are preserving, they still resume their fertility normally, and they will have the conceptions which are natural. They may not even require this. That is one. And secondly, even if using these kind of tissues or these gametes, they may not have the successful pregnancy. That is also at the same time equally important. And it is very important that it does not imply that child survival into the adulthood is certain. We are preserving the fertility, that doesn't mean. So it should not give the false sense of security to the parents. That is also very important to understand. And whenever the children are little older, old enough to understand, once we counsel them with the help of the counselor, then there is something called as assent of the child. That is child will be given an appropriate information by the counselor and explain the procedure, and then that has to be documented. That is something called the assent. So that is important. And this is certain situations where we require the help of the clinical ethical review board. So that we have already discussed. I will not go much into detail. So that's what. So these are basically the program workflows, like when the patient, so it is similar, like when they have the, like any new patient, then they will consult, then there are coordinators. Then if there is no fertility preservation, that has to be documented. If there is fertility has to be preserved, then we will segregate into pubertal, pre-pubertal. If it is male, then testicular tissue, female, ovarian. Then if it is pubertal, then we have these other options. And male, we have the semen freezing or tissue freezing options. So generally, these are the workflow of the programs. So yes, that is very challenging, and especially the pediatric population, we get these challenges. But definitely then we need to find out these solutions, specialized units basically, and special program coordinator and counselors for that. Okay, so we will move on to the next.
The fourth clinical scenario, patient details are a 23-year-old man. The cancer diagnosis is flow cytometry confirmed and immunophenotype consistent with acute myeloid leukemia, AML.
So this is again a male patient with a AML. So how we can go about these?
So again, AML is a heterogeneous disease. These are a spectrum where you can have a very curable malignancy like acute promyelocytic leukemia, or on the other hand, you would have a high risk acute myeloid leukemia, which will require stem cell transplant, which is kind of 100% infertility. Second thing is the medical condition also of the patient may be very variable. Sometimes they are very sick and you have to be like very prompt in treating them. Sometimes you have some time to do semen cryopreservation also. So given the ease with which we can do semen cryopreservation, if there is an opportunity, we are not going to waste this opportunity, and I will recommend doing semen cryopreservation in a garden variety AML patient. But at the same time, I will have a look on their hematological parameters.
Yes, so definitely, like it's, as you said, it is like an emergency. So we have to have like 2 to 3 maybe semen sample we can take and have the maximum, I mean, that we can do in a shortest possible duration. And but yes, sometimes there can be a problem with the quality of the semen as well as the DNA integrity of the semen specimen. So that also we need to check. So that is again, of course, here we deal with the emotional stress, and sometimes there can be difficulty. Sometimes yes, there can be difficulty in giving the semen sample and all. And so if it is too much emergency, we don't have, or if the patient has a difficulty, then we can go for the surgical procedures like testicular extraction, or it is like a microtese or oncotese. But yes, when any time the surgery has been considered in the hematological parameters, so chances of the bleeding and the risk of the surgery, it is like again the increasing. So definitely the first preference would be the semen freezing, and with the 2 to 3 semen sample, I think that should be the thing. This is a additional options. Fine. So we'll move on to the next scenario.
So the clinical scenario 5, where the patient details are 32 years, nullipera, mass in the left breast, 3 centimeter irregular, family history, where the maternal grandmother has a pancreatic CA, maternal aunt post-menopausal breast CA, and maternal uncle had melanoma. Cancer diagnosis is core needle biopsy revealed invasive ductal breast CA, ER positive 95%, PR positive 95%, HER2 new positive, and there were no nodes.
So I think we can take madam's opinion on this. So for these patients, what challenges we would face?
She's 32-year-old. So she has a family history where grandmother had a pancreatic cancer, which belongs to BRCA spectrum. So though it is not triple negative cancer, but still would discuss the option of genetic counseling and BRCA testing with this patient since she's 32-year-old. Now, when we offer her fertility preservation option, we have to know whether she's married or not, whether the option of embryo cryopreservation exists.
Yes.
And if she turns out to be BRCA positive, then we have to discuss with her that there are 50% chances that the cryopreserved embryos might have BRCA positive chances.
Yes, so that also. So here is the role of the genetic counseling, which is very important. And then if it is positive, then we can discuss the further thing, that is nowadays pre-implantation genetic testings on the embryos. So we can at least give them an option and accordingly do the PGD and cryopreserve only the competent embryos. Rest embryos can be discarded. Here, from our point of view, I need to add on like what special precautions to be taken during ovarian stimulation, because here it is like yeah, ma'am, sorry, you wanted to yeah.
But she's HER2 positive, so the cancer is HER2 driven rather than ERPR driven.
Okay,
But
yes.
still maintain the estrogen levels
Correct,
to
correct.
lower level.
Yes,
but
that
it is
is
HER2
but
positive cancer.
yes, so that is one. But definitely, so just to add on from our side, so there are we use nowadays a protocol with a letrozole and all to keep the estrogen level as low as natural cycles during the stimulation. So very important point here I want to discuss about is the stimulation protocol. So it is not like always, so generally that was sometimes it is mentioned by the oncologist, no, it will be difficult, like how we can go for the stimulation in such a patients. But when we start the stimulation, throughout the stimulation and even after the egg collection, we continue this letrozole, which is aromatase inhibitor. So definitely it will reduce the estrogen level. Usually in the normal stimulated cycle, estrogen level can reach as high as around 2500 to 3000 picogram per ml. But in a natural cycles, it is generally around 150 to 200, maximum to 250 picogram. So with the letrozole, we can maintain that low of the estrogen without compromising the oocyte quality and the number and the M2 rate, that is maturation rate. So this is very important. So that we can realistically do. So definitely these kind of patients we can very well, that is something letrozole based stimulation protocols. So that is very important. So just from my side, I wanted to add, nowadays, initially there used to be a long protocols, which was known as GnRH agonist based, which used to take 3 weeks. But nowadays, with the use of the GnRH antagonist, we have the protocols where we can use, we can do the stimulation as low as 8 to 9 days, maximum 14 days. And this will suppress the internal LH immediately. And this is generally started from day 5. And in such a patients, generally we prevent hyperstimulation, because same again, in the cancer patients, we don't have to add on the complications. So we need to prevent the hyperstimulation. So these protocols are used where we can even again continue the GnRH antagonist after the stimulation till they start the chemotherapy or whatever further treatment, so that to make sure that ovarian hormonal milieu remains, I mean, normalizes faster. At the same time, we can give the agonist trigger, so there is no hyperstimulation. So this is very important availability nowadays. And what would be the I mean, differences, just because they are the cancer patients, because there is a affected function of the HPO axis. So there is a decline in the fertility, of course, because of the malnutrition, catabolic state, raised stress hormones. There is a reduced response to the stimulation. So we might require the higher dosages. And as ma'am said, if there is a BRCA mutations and all, oocytes are prone to DNA damage. So these are our basically challenges. So, but still we have these kind of the protocols. And as in females, we have different this, like if there is a, I mean, we have like in vivo, we can do like mature oocytes, embryo freezing, then it can lead to live birth, or we can do the tissue cryopreservations. And later on, we can do either a transplantation or in vitro maturation and then make the embryos. So these are the different options. So in such a case, important was to offer a genetic counseling and offer a PGD. And of course, because if this patient is on the therapy like trastuzumab or pertuzumab, so definitely they are contraindicated in pregnancies. So contraception to be discussed in these patients. And we have to give little time further, like around minimum 6 to 7 months time for delaying the pregnancy. So that is very important for these kind of patients. So we'll move on to the next scenario.
The patient details are 29-year-old married female, repeated episodes of chest pain and shortness of breath, HRCT suggestive of 6.6 into 5 centimeter anterior mediastinal mass. The cancer diagnosis is primary mediastinal B-cell lymphoma.
Okay. So, sir, in, how much time can be offered in such a case for fertility preservation? So, how urgency is there for the cancer treatment, because she has a big mass also and repetitive episodes of chest pain and
correct. So this is a higher grade than the Hodgkin disease. This has tendency to have rapid proliferation, and also you can have some unexpected complications like SVC thrombosis, embolism. Sometimes they become breathless. So usually in such patient you will not have much of time to do. But once in a while you can have a patient who just present with cough. You have some nodes around trachea, and in such cases you probably can wait.
Okay.
I think second important issue for this person would be that no, this disease, its treatment has changed in last I think 6-7 years. We have moved from R-CHOP to a R-epoch based protocol. With this, the cure rates have become very high.
Okay.
But at the same time, this R-epoch protocol doesn't cause that much of infertility.
Okay.
So we also have to take into consideration the risk which is minimal here, and in terms of infertility and the risk of deterioration and complications. So based on this, probably individual patient you would be able to
give
decide.
the options.
Yeah,
Yes. Yeah, so maybe we can give her options because she's married, so maybe embryo cryopreservations and all, and that maybe 2 weeks, 3 weeks time that can be. But so here maybe because it's a mediastinal mass, so because we have to undergo the anesthesia for the oocyte, I mean egg collection and all, again there will be a problem. So
most of our patient in like patient, they present in a very bad shape. They are already breathless. They have SVC syndrome by that time. So most of the time it would not be feasible in our practice, in my opinion.
Correct.
But if it is feasible, then
maybe
you can
think.
consider.
Yes.
And definitely this is not without risk. They have other complications, sometimes tumor lysis, etc. So
exactly. So case to case basis, we need to decide like what could be done. Yes. So yeah, so here then from our point of view, I just wanted to add, because yes, one is we need to assess how one is the risk to the infertility, as you said, available protocols. If it is a lower risk, then which kind of the treatment, I mean fertility preservation option to be offered. And secondly, if we have the time to go for the stimulation, then we need not wait for the conventional ones, like to get the periods and start on day 2, day 3 of the periods. So there is something called as nowadays random start approach. So anytime in the menstrual cycle, anytime patient visits, the same day we can start the stimulation. So nowadays, those kind of the protocols we are using, and that is called as a late follicular phase, then luteal phase protocol. So I'll not go into details of the hormones, but nowadays there is a in the recent research, like in the ovary, there are waves of the follicular development. So we don't have to wait for the menstrual cycle day 2, day 3 as a conventional to start. So every time at any given point of time, there will be few follicles which are already ready in that phase of the development, which we can pick up. So based on this theory, at any day we can actually start the stimulation. So it can be late follicular phase with a different hormonal approach, luteal phase start. So we can use such a kind of stimulation protocols in such a scenario, and of course depending upon the urgency. So and as we discuss, other risk factors to be considered. Okay, so we'll move on to the next case.
Here the patient details are 32 years old, para 1, live 1, 5-year-old child with a history of right salpingo oophorectomy for stage 1A borderline ovarian tumor. The current diagnosis is left adnexal mass.
Okay, so one question here is,
in this case, is it worthwhile to refer her for a fertility preservation consultation, as she has already having 1 kid?
Of course, we have to discuss with the patient, but I would not really opt for it if the decision is up to.
Yes, it is up to patient. Yes, but we need to tell. So it is like, so even as per the guidelines, like even if patient is having 1 kid or even if 2 kids, at least we need to discuss that with the patients. Yes, these are options are there, and ultimately the decision lies with them and we have to follow. But at least we should discuss, we should document with us, yes, these options were given, and then accordingly. And yes, if suppose she wants to go for it, then how we would go in such a case?
Depends on the size of the mass.
Yes.
Whether can we remove that adnexal mass without rupturing it? Since she was already a borderline ovarian tumor,
Yes.
my next suspicion will be recurrence in the other ovary. Might be borderline or might be an invasive cancer. So every attempt to be given to preserve as much as ovary, but remove the cyst without rupturing it.
Yes.
But that becomes very
difficult.
Practically becomes difficult.
So if we get any tissue, of course, we would like to preserve that, and at the same time, so definitely it becomes difficult.
But if there is a cancer in that ovary, I don't think so. That becomes ethically right to conserve the, because
correct. So if there is a cancer, and that we will come to know by the scans and other maybe, and
no,
then
you will come to know only with
the histopath, sorry. Yes, not on this, but histopathology, if that is there, then there is no point, at least preserving those and retransplant. When we transplant, auto transplant that, then definitely there is a chance of the recurrence. So definitely, but because it was a borderline, so we don't know what it would be. But definitely, so 10% ovarian cancers are diagnosed, yes, below the age of 40, and borderline ovarian tumors and malignant germ cell tumors, they have the favorable prognosis than the epithelial that we know. So definitely these fertility sparing surgeries like unilateral cystectomy or unilateral salpingo-oophorectomy, as that was done in her case prior, so that was there. But some patients have like 46%, around 45-46% will have the spontaneous pregnancy, and later on, generally when she completes the family, we can complete the surgery. And so this one, there is that in cases of the ovarian cancers, so there are these safety concerns. One is for the hyperstimulation, then oocyte retrieval also, and as well as the ovarian tissue cryopreservation and autotransplant, as we said. And it is not ethically right also, if the cancerous tissue is present, then we cannot utilize it. But then still, if there is, then further we need to always, we can discuss these options of the third party reproduction, like using a donor eggs or maybe adoption. So those options are at the end always there. So there is nothing like there is no hope or something. It is not like that. So those options are always there. But here we are trying to give as far as possible their biological child. But if not, these options are always there at the end. Yeah. So the next
clinical scenario, patient detail, 22-year-old woman, nulli gravida, current diagnosis, recurrent Hodgkin's lymphoma requiring bone marrow transplant as early as possible.
So I think, sir, you can give.
So even if she requires transplant, I think we can spare 7-10 days for stimulation and correction. So because the high dose conditioning is going to be universally associated with infertility. So definitely, if feasible, I will like to offer her.
We can get that much. But sir, about the before transplant, we need a radiation, and for that, so we get that much time for the interval.
Yeah. So Hodgkin's has a very slow growth of
yes.
So it should be, but it obviously will matter what was her previous treatment. Has it rendered her already infertile? Are you able to do that?
Okay, yeah. But usually we will get the time for the oocyte cryopreservation. So definitely. So yeah, so definitely the treatment of this, it is, yeah, as you mentioned, it might lead to the premature ovarian failure and all that. So there is that, if the time is permitting, we'll do the oocyte cryopreservation, or even we can go for the ovarian tissue cryopreservation. But here also, again, in the lymphomas and all, involvement of the ovaries has to be again confirmed. So, sir, based on this, what is your opinion? Like every time?
So, So I think this is a very broad statement that hematological malignancies, the ovarian tissue transplant is associated with risk of reseeding the body with the tumor. Yes. But I think it will vary from disease to disease. For example, Hodgkin disease, it tend to be in nodes. So I will not be really worried about that. Okay. Even the literature about the recurrence of cancer after such kind of this is divided. But definitely for hematology, blood-borne malignancies like leukemias, etc., and where you are collecting such tissues before treatment, so there would be higher risk of reseeding. So it definitely should be avoided.
So, sir, in that case, is it right that we should go for the MRI or PET for before life?
But you still have microscopic evidence of disease like that. So it would be associated. Yeah. And second thing is we are at such a juncture that no, this is probably the last treatment option for her. If she fails, she is going to, I mean, whoever is going to lose her life. So definitely we have to be very careful now.
So it all depends upon the stage and exactly what is the malignancy, and then accordingly we can decide.
Correct.
Yes.
So
Okay.
I think another issue is like we always speak about fertility, but also sparing their hormonal function, especially in
It
females, is
matters.
very
Yes.
important. And many times our post-transplant patient, no, they are on hormonal replacement, etc. So maybe for that, can we do something like for such patient?
Yes, we can go because they undergo premature ovarian failure. So definitely they have the symptoms of the early menopause, and that is because of the less estrogen. So in such a patients, basically we start the HRT, that is, I mean, natural estrogens, and then to restore even their menstrual function, because of the same they will have the irregular menstrual problems, and sometimes they may not have like early menopause. So till the age of natural menopause, till the age of the 40, we can start them on a HRT based on their, so we'll be doing their baseline assessment first. What is the risk of giving the estrogen? So generally, if there is no hypertension, no other high risk factors, no history of the stroke and other problems prior, then definitely we can give. And with this HRT, they have the very good normal life. And sometimes they have the even sexual dysfunctions because of the dry vagina and other problems. So we give the local estrogen creams that also works very well. So these are all again there comes these kind of the counselings, gynecological support from that, and the counselor supports. So we can do usually these kind of things. Yes, sir, similar. Yes, it causes a lot of breast cancer. Yes. So generally HRT has the high estrogen content. So we can use even the low dose estrogen, low dose ozipils also in such a patients, because these are generally young patients. So it is said that ideally it should not be used after the age of the natural menopause. So till the age of the 40, we can use it because it's a premature. So later on we will not have these problems in them. So definitely we can use that. Okay.
Next is, what are the challenges in survivorship when the fertility preservation options were not offered during cancer treatment?
So I think ma'am can give a light on this. Like, so still sometimes the fertility preservation options were not given, or maybe not available. So sometimes if the patient do come to you and later on, because you deal with the gynecological malignancies also, so do they have the regrets, or how, you think
Most
like,
of the times now the trend is changing. The oncologists are discussing the fertility preservation options with them. But some of the times even the oncologists are not aware of the, either not aware or they don't have time.
Options, or maybe the available
Yes,
options are not there, like to refer to
so
whom, where.
patients do come with it. A very few patients have a regret.
Yeah.
Even the patients, for them, surviving from the cancer is the main target.
Yes.
So I don't see so much, but they are not initially also counseled. Only a few patients do ask for it. To be very frank, most of the patients themselves say we want adoption.
Maybe, yes.
The point discussed is if they themselves don't survive, or the risk of malignancy coming back is higher,
yes,
then we would rather go for an adoption. I think that is a good enough option for this some of the patient instead of taking risk. But we do have to discuss these options with them.
Correct. So it is person to person variation, and it is, I think, it depends on how different people will take it differently. And yes, because some people might say directly adoption is a fine, but nowadays even practically that has become difficult because of the central adoption laws. Again, we are facing difficulty there, because for our also lot of patients, when they don't conceive and even the surrogacy at stake, so they have again the long waiting time there and centralized process. So that is also one challenging thing. But definitely yes, nowadays these scenarios are little less, and we want to make it to the zero. So at least our each and every patient has been given the option, so that later on they will not have the regret. Yes, that can be done, sir. Yes. Hmm. 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 Yes, sir. Huh. Hmm. Very, very difficult. Yes, sir. Yes, sir. Same. Very difficult because even so we face those problems because those repetitive IVF failures, and even nowadays when the surrogacy is not there, I mean it's altruistic, very difficult. So they are not even, they have registered 2 to 3 years back, still they are not getting the this thing. So maybe we can have the consideration. And again, there is the age limit, like age less than 50 years and combination of the both age. I mean they have some limit for that, where again there is a problem.
Another
So
thing is that when the surrogacy law has come, I think some consideration should have been given to the cancer patient because it is
exactly, yes,
means
because
at
for
least
them,
when we infertility specialists were asked to give some explanation or
yes,
something
ma'am,
till
it
3 months,
is,
but
yeah,
have this point been brought up or not? Because none of the gynae oncologists were in the
in the
forum.
committee, yes, yeah,
Nothing has happened and nobody has put forward this word, but it becomes very difficult to counsel these patients when they can't go for surrogacy.
exactly, ma'am. That was similar. There were a lot of things. It was a case against. I mean, it is still going on. People are putting these points. It is just a one-sided law because yes, that was like to prevent whatever was going on with the celebrities. If you are doing surrogacy for second or third kid, it shouldn't be. It is not a luxury, but it's a kind of a treatment for really needed people. Sometimes, if the uterus has been removed, there's a congenital absence of the uterus. Kind of these patients, cancer survivor, where uterus has been either removed or there is a radiation, post radiation, then these are the real candidates. And no one will be doing, I mean family person doing surrogacy, most of the people they hide it from the family. I mean we have seen so many people that they can't tell it to the family, we help them, okay fine, and they take it forward. So it is really difficult for them. I mean, so definitely that is going on. We just hope that those amendments will come and that will be, there will be help. Yes. Mm. Yes, different, and it's a social stigma because then people will not accept that child, and for which we are doing it to create a happiness. So there will be again a big social problem to the child, that we don't want to introduce any psychological issues to the child itself. So definitely it's a one-sided, and I think yes, as you rightly said, this point has also to be added. What about these patients of the cancer survivors, those who are requiring these kind of options? So this is the kind of a treatment for them. No, it's not a luxury. So that is also taking care of a proper. They had one point also ki if the surrogate mothers are getting exploited, but actually it is not. They are getting that compensation. We are taking their insurance. We are taking a good care of them. So with this all regulated thing, definitely we can do for the indicated patients, but not non-indicated patients like. Exactly. So first, yeah, and indicated, like if some uterine factor, not just like. So I think those points to be added. Let's see if few amendments can come up. So we'll also put forward. I mean, people are doing it. Associations, fertility associations are putting forward it through the lawyer and all. So let's see. We are waiting for the same. So yes, the last we'll just discuss a few last points where again one thing we wanted to discuss about the financial consideration. So this we have discussed like fertility preservation to all, so there is irrespective of anything. And then one is this financial consideration. What about the insurance cover? Still we don't have the insurance cover for these kind of the, like especially the fertility preservation. So because it is still, fertility is not considered as a, even in a routine insurance, health insurance, it is not covered. And even in the cancer patients, it is not considered as a loss of, because of the cancer treatment. So still this is not covered. So we can, think about, or either developing some kind of with the NGOs, some funds, some trust where they can provide funds. And literally speaking, actually cost wise, for the male, it is not very costly. It's hardly like, 10,000 for a year semen sample preservation, say 3 to 4 samples, and 5,000 we can have the per year, what you can say, renewals. And for the female, for the stimulation purpose, and that making embryos and all that, maybe as it can be as low as 85,000 to 90,000 for that first cycle cost and 1 year preservation. So I think we can do something for this, where either insurance companies to cover it, or I think some charitable, some NGOs and all maybe. So I think then the financial burden will be less. So that is one, maybe
It's
we can
surprising why they should not cover it if it is because of cancer causing infertility, no?
Yeah,
Forget
it is-
about
yes.
cancer and fertility treatment. Otherwise, also fertility treatment is never covered. Forget about fertility treatment. How much of the obstetrics is covered? There is a
It's
gap
very
line
low.
for every 50,000.
Yes,
After
yes,
50,000,
capping,
none of the
yes.
insurance companies cover the
No.
obstetrics.
Yeah, even that is they have not covered. So I think
But
these are
that's
the
a
things.
surprise. Why it should be? No, it's a disease.
Even if you see the institution coverage, whenever an institution gives, even they don't cover. Up to 50,000 is the limit that is given by most of the institution. So this discrepancy is always there in a system. I think they should fight it out with all these things and get it sorted out.
I think that is very much needed, because otherwise this won't be
this
promoted.
can be fought. So one of our patient had his claim been rejected because it was labeled as steroid induced diabetes, and ultimately he was destined to develop diabetes, and he was told that "Nee, this cannot be covered." So this was dealt in consumer court, and the final decision was to cover it because this started with the treatment for cancer.
Correct.
It
And
led to
it's,
aggression, and it was covered. So if maybe individual
I
patient
think
can
we
be
should
asked to
yeah,
Even
that
the
has to be-
insurance form, when we operate, insurance form by mistake, if it is written patient is null gravid, even
Still
for
they
the
will not,
even the
correct.
oncological procedure is not covered. Claims get rejected.
Because then they seems that
We
it
have
is
to give
fertility
multiple
related.
explanations saying that this treatment was not for fertility.
Yeah, they require a specific sentence like this, ki this was not done for the fertility kind of thing. So that is one, yes. So something has to be done for that. So that point has to be fought for, like why there is no cover. There has to be a cover of these cases. I mean,
There's something frankly speaking as a weird one. Because my sister is a mentally retarded. So I wanted to buy a medical for her. So I approached almost all insurance companies. They just say we as a policy we don't issue medical to a person who has a mentally disability. So I was fighting with them
but
in a way she can get a fever, she can get a pneumonia. So at
everything
least you need
correct.
to cover for this. If she has some issues with mental retardation, then you don't. But you can't reject a medical policy just because she has a mental retardation.
Correct.
So then I think I was doing it in 2018 or 19. I had written to PMO also.
Okay.
This is what is happening. And after I think 2 years, they have now changed.
Okay.
So they are allowing to. So only one insurance company agreed to issue me a policy. That took me the 30% copay. So I was the primary insurer. He had the added. And then for her, I need to pay 30% as a copay.
Correct.
And that too only 5 lakhs cost. I was like, for 5 lakhs, if I'm paying 1.5 lakhs as a copay, then it doesn't make a sense.
This 5 lakh limit is for every, if you have got a MI also, they will not renew it. They will keep it only at 5 lakh. You will not get more than 5 lakh.
That is an issue. So see, for a normal, they may be saying you can buy whenever you want. But for a special condition to get an insurance cover is really fair.
Yes, exactly. So I think then that is the challenge, because then here, as it's a critical timeline, their main focus is of course the cancer treatment first. That is the primary focus. These are all collaterals, secondary. Then it becomes difficult, and then these challenges are not taken care. Then definitely there will be. People will not be encouraged to go for this. At least if this is covered, they are getting the financial funding. So at least they might think of this. So maybe I think some either a insurance or some private trust or NGOs can have the funds and maybe provided the fundings that has to be, thought for. So that is one. And another, of course, this we have discussed, like there are usually disputes over the frozen gametes, embryos and tissues. So then that has to be properly documented, what can be done after the death of the patient and who has the right. And of course the same, that is posthumous assisted reproduction, also the posthumous reproduction. So what are your opinions like on posthumous reproduction? Like if the consent is been given, how, I mean, yes, ethically, I mean, as per the guidelines, what they are given, if the properly documented, we can go ahead using the gametes. But what are your personal opinions like?
It depends on the family members what the other
Mhm.
person partner wants to do probably.
Yes, I think. But yes, documentation plays a lot of role. So if the documentation has been given, anything, sir, you want to comment?
Yeah. So I think leave this ethics and
Mhm,
regulation apart. I don't think if the person what we are there to prohibit this. And as you said, there is a lot of hurdle documentation, and no,
mhm,
sometime this has typically happened with a treated patient who lost a male relative, and a
mhm.
female partner wants to go ahead with the pregnancy.
Yes.
And it is not easy. It is, I think, long
Difficult.
legal battle, I guess.
Yes. Yeah, but definitely that is one, and social also
Yeah. So, but
problems.
my personal opinion, if the person want, he or she should be allowed.
Yes, ideally, that is true, because that's what I wanted to discuss. One case that we had currently posthumous this thing. So this was a couple of 42-year-old female and 48 years old male. So they had a IVF cycle which was failed, first IVF cycle, and after that husband expired. But at the time of the first cycle, we had the sperms frozen. So that was always in the IVF cycle, we freeze as a backup sperm. So that was frozen, and we have the detailed consent formats as per the guidelines. And it was mentioned that after the death, spouse can use the gametes. So that was all properly mentioned, signed. And maybe after like 2-3 months of this, when the female, I mean, she came wife and she requested, yes, I want to go ahead. Then actually we had her counseling session 2-3 times, and along with the family members, of course. So she had a lot of support from both the families, and then she showed that interest, and we had the documentation. So then she underwent another IVF cycle with those frozen sperm, and now she is like 32 weeks of the pregnancy. So that is ongoing. But yes, that requires a lot of courage and a lot of support also from the social, because again there is a right about the child and other things also. But yes, in a court of law or whatever the legal things, when we have the documentation, that won't be a problem. So that, yes sir, anything?
I think my experience was not good. The moment that female approached the place where it was frozen, they bounced back. They said this is not allowed.
Acha. Okay, in the your
Yeah.
acha,
So I think this needs to be clarified.
clarified.
If it is documented and if it is allowed, then
Yes.
it should be, because no,
Yeah,
they are lost
correct.
person, and if you want to get.
Yeah. So, and what happens is here, the focus is mainly about the need of the documentation. So obviously, so yes, we can't deny, because reproduction as a joint project, and it needs a properly documented. Most of the time what we see, like even this was, we never expected that this will happen in that couple. So it was a routine case, we go ahead, but that has to be so routine, taking a proper documentation. So even while you are taking one sample freezing, so you have to be so meticulous about ticking all the boxes, taking all the consent. Sometimes patient says, no, what to write this? Oh, how you are taking this? Ki after my death, what I'll do? But still we make sure, no, please mention that. That is mandatory. These fields are, sometimes we have seen some consent forms, nothing has been written, just a signature, then it is not valid. So it has to be written with their handwriting own, this thing mentioned. So we make sure that even while taking a single consent, please fill all those mandatory fields. If they are not understanding, we make them understand ki please you mention, and that was luckily properly mentioned, taken. So I think when we have that, we can definitely go ahead, and at least they'll be completing their dream. So it is nothing like it if we can give them that kind of thing. Yes, it is a legal. No, as such, not guidelines, but proper documentation, consent is needed. And as per our fertility guidelines, which comes under a law, we have a particular format for freezing the gametes, those consents. And there it is specially mentioned, like what is to be done with these gametes, either embryos or egg or the sperm. In case of the death, what you would like to do, either a discard, or give it to the, allow your partner to use it, or donate. So those you have to fill accordingly. So those are as per the guidelines. We have those consent forms accordingly.
What about if there are unclaimed?
Unclaimed, then we have to discard.
After how much time?
So yes, it is like it is properly mentioned that for this storage, we have like every year renewal. So we approach the patient, okay, now this is the renewal part, and they have to pay those fees, which is very minimal, 5,000 rupees per year it is actually. So they will have to renew, and accordingly and it is mentioned like 3 months after there is no contact, like after the renewal period, then definitely we'll be discarding it that way. So one more, we had this in this year only, live birth in the breast cancer survivor. So she is 36-year-old female. She is a doctor by profession. So she's a pathologist, by the way, and she had breast cancer at the age of 26 years. And for her, like unilateral mastectomy and followed by chemotherapy was done. But that was unfortunate in her case. 10 years back, that time, she did not get any option of the fertility preservation. So that was, and then when she started her family, like 10 years later, her AMH, that is the egg reserve marker, was very low. It was 0.5. So she underwent IVF cycle, but it was a miscarriage. So that was lot of psychological challenges, because by that time she was in the process. She understood that is because of the chemotherapy and all that AMH was less, and then that was a miscarriage. So we had a multiple session of counselings, but later on she accepted the donor eggs. It was a great challenge, but accepting the donor eggs and all. So here again, I mean, in the counseling, then we try to, because of the egg donations or the sperm donations, see, it is still the similar analogy is like any organ donation, right? We do so many drives, like post even we should donate the organs, and kidney transplant, liver transplant happening, all the organ transplants. But for the egg or the sperm, it becomes a ability sense, right? And it becomes a social stigma. So that was thing, like how can I accept someone's egg? Then what about the genes? What about the intelligence? What about, personality? But then yes, it has been proven, so genes are required for the structure. Then whatever intelligence, your behavior ability, that is all the expression of the genes that you will be providing the environment. So all those counselings, I mean, required. And then finally she agreed for it. And then again, here people would not want it socially to be known yes, it was a donated egg or donated sperm, or sometimes a donated embryos. Then we make a lot of things, like it will be exactly feature matched as compared to the parents' features. Like if it is the egg donor, then mother's feature. If it is the sperm donor, then father's features. Then according to height, skin color, hair color, eye color, those will be matched. Then combinations of the blood group, and then accordingly we'll have the baby. So I'll show you the photo. So this was our baby, exactly matching. So I have not put a parent's picture, of course, because it was not consented. But yes, so this is our that baby after this thing. So with the egg donor, but perfectly matched. She was very happy, because otherwise there will be a social problem again, how the baby is looking like to someone else. So these are the challenges. But so we explained them all the process, how we match the donors, how we take the donors, and then finally it was agreeable. And now she's happily having this kid of 6 months.
How do you find these donors? Is the eggs of a previously used IVF patients, is it used, or
no,
you specifically find a
specific donor? Because the eggs of the previous IVF, they definitely have some problem. And usually when we are going for the IVF, majority of the times it will be either egg factor or some other problems. So, and they may not donate. So we don't have a consent, like only someone will say. So those are the specific donors which we have to find out. But it is very difficult to have the appropriately matched donors. But yes, we try to do that, because that is then the complete work or complete happiness will be providing. Otherwise, just getting a baby and later on if having these social problems, then they will never be happy on all these lines. So basically that was the thing. So that's why as far as possible we try to give own biological child. I think that is much easier, and if not, we have all these options that way. So yes, with this, I would like to conclude, because already almost we are at a closing time. So this was one study where it was a pregnancy and time to pregnancy in the cancer survivors. So this was a nationwide study in Dutch females. So definitely in the cancer survivors, what they observed was, yes, there is a definitely longer time to conceive, but there definitely they did not have any increased risk of the miscarriage or stillbirth or induced abortions. but they have the increased risk of the delivering preterms and all. So there is, even in the cancer survivors, we can have the pregnancies with a good outcome with a proper care which we are providing ultimately. So finally, our goal has to be, so at the end I would like to conclude, we have to form a good oncofertility setup where these would be the characteristics, like no delay in the appointments. So we should have a good coordinated team effort. So time to time coordination with the fertility and oncology team, good navigator, and then the customized stimulation protocol, either random start, low estrogen protocols, then advanced cryopreservation unit, basic to advanced fertility treatments having under one roof. Everything should be one roof. Patient should not be again and again going to one place to other place. And availability of these services 24/7 with a dedicated team, and at the same time genetic testing, genetic counseling. So we require a team setup, a model of care where all these coordinated efforts should be taken by both oncological team, fertility team, and again going back to the after cure, again completing pregnancy. So that has to be taken. So I think we should make an effort to form such a teams. Hopefully we'll be doing it soon. So definitely I am ending the session with a quote that I am realistic, I expect miracles. Let's see how we can formulate all this. So thank you so much. I thank all the organizers for giving us opportunity. Now the third time conducting this workshop, and I am very thankful to Dr. Sampada ma'am, Dr. Nikhil sir, Dr. Vausap sir for attending and giving enlightening information about this topic. Thank you so much. Okay. So I'll end the session. So just to mention, we have the last time we had inaugurated this our book Oncofertility Manual. So if anyone wants to read in details, of course it is available. You can go through. Thank you so much.
Thank you.
So, good evening, all. Today, so without wasting any time, it's 3 minutes are left, but we'll start with the stats workshop. So, what we decided at this workshop is rather than having a predefined pattern, it will be more of kind of an interactive session where you can basically ask whatever questions you want to ask. We have already got around 12 questions online before the workshop started. So, we'll start with that, but feel free to stop anytime and ask question. I'll request everyone to come ahead. Sunil, today. Divya, aa jao, aage aa jao. Come ahead. Yeah. So I'll request now that we have got settled, I'll request Ashay to ask what was the first question which came.
Basically, we have various questions which are there. The first question is about sample size. So what are the essential elements or information required for calculation of a sample size?
So Atanu, the question is, what are the essential elements which are required for calculating a sample size?
Okay. See, for calculating sample size, first things we need to keep it in mind about the study design. So irrespective of that, what things we need, we have to keep on mind that what about our study design, because always sample size calculations depend on the way you are conducting the study, and that how we are going to conduct the study, that is basically nothing but the study design. So broadly, if we know, or if you say any kind of study design in banner of the clinical research, if you'd say, so three kind of studies, mostly study designs comes mostly, that is cross-sectional study, case control study, and cohort study. But so first thing is the study design need to be defined. Once that is done, then other essential parts are like, that type 1 error, type 2 error. So nobody considers type 1 error and type 2 errors during the sample size calculations, but as an alternative or mirror image of type 1 error and type 2 error is considered as the confidence interval and power of the study. So once commonly we are having way to consider the power of a study. So I will come one by one ingredient over there. So power of the study. So mostly we considers 80% or 90% power of a study. So it's this power of a study can go up to 100%, and the minimal value of a power of a study could be 0%. But in terms of the different studies been conducted earlier and the way people accept any studies is having power enough, so the conventionally we are having 80% or 90% been considered as adequate power. So if you perform any study, so it is expected that you should consider the power as 80% or 90%. So obviously, if you are having power as a 90%, then the study is much more strengthened, and obviously your sample size is going to be more. So this is the second part, is the power of the study. Third part is this confidence interval, or it's just reverse part of that type 1 error. So anyway, that power is that reverse part of the type 2 error, and type 1 error and reverse part is basically the confidence interval. So if you are having conduct a study with high confidence interval, in that sense, your type 1 error is going to be low. So once you are going to be low type 1 error, that's mean you are going to be strengthening your study by taking more sample size. So this is two part. One thing is the confidence interval more, type 1 error is low, your sample size is more. Your confidence interval is low, I repeat, your confidence interval is high, type 1 error is low, sample size is more. Your confidence interval is low, type 1 error is more, your sample size is going down. So this is the relations stand between confidence interval and type 1 error, and your sample size. So these are the 3 points I mentioned. Now there are few others component need to be calculated or considered while you are calculating the sample size, and those depends on based on again the study objective, the study, how your study design objective is aligned with your to support your goal. So for that, other parts there, I think we can discuss one by one later on. So mostly these 2 parts: study design, 3 parts: study design, power, and type 1 error. Dr. Vijay, I can't hear you.
Okay, so what Dr. Atanu has told us is it will depend upon the study design, and study design can be anything. For example, I'll give you an example like for a preventive study which Dr. Ravikant will be interested, he would want a study design. Let's say that he wants to find the incidence of gallbladder cancer in the Ganges blood. So that would be a cross-sectional study. For that, the sample size calculations will be different. If as a clinician, I want to see, I want to give a drug in gallbladder cancer patients and to see whether it benefits or not benefits, the sample size calculations will be different. But the sample size calculations, which we will be largely board upon 2 parts, that is, one is type 1 error. So what is type 1 error? To simplify, type 1 error was the first error which got discovered in stats when you do sample size calculation. So this is the error which talks about false positive, which means that it stops you from doing a false positive error. So obviously, let's say in a drug, if you're going to falsely say that the drug is useful, then that would mean that the drug would get marketed for that use. It would get it, most of the times it will be expensive also. So you want to avoid false positive results. So that is what the type 1 error is for. Type 2 error actually helps you to decrease the chances of having a false negative. So type 2 is false negative, and that is also known as the power of the study. So when you say 80% power, there are 20% chance that there can be a false negative. Okay. When you say 90% power, there is 10% chance that that can be a false negative results. Now, obviously, this combination of type 1 and type 2 error depends upon the feasibility. Like you would or like to have a 95% power, or you would like to have nearly 100% power, but it's not feasible because, as Dr. Atanu suggested, as the power keeps on increasing, the sample size will become large. And if you want to go to your 100% power, sample size will be very large. So it is not feasible to get such types of sample size, because at the end you want to do the study and complete the study in a stipulated amount of time. And hence type 1 and type 2 error are also dependent upon the feasibility of doing the study. So one thing more I like to add is that whenever we do a study, the sample size calculations is better to get involved with a statistician and needs to be done at the initial phase itself. Like for example, I want to do a tomorrow study on some drug Y to be given in head and neck cancer so that it prevents the disease from coming back after doing surgery. Now it's better that when I get this idea, that is the time I do a sample size calculation, because all my discussions with my colleagues about how many years it will take, what would the kind of resources required, both in terms of manpower, time, patient, and money, will actually be dependent upon sample size calculation. So it's always better whenever you get an idea, you run it by a statistician, you get an idea about the sample size that is going to be required. And depending upon that, then you have a discussion with your colleagues whether the idea is feasible or it's not feasible. I'll give you an example of feasibility. Let's say that I'm sitting in Tata Memorial Hospital, which is 40,000 patients per year. And I need a study for which I need a sample size of 400 patients of head and neck cancer in stage 3. We see 12,000 patients of head and neck cancer, and stage 3 we see around 7 to 8,000 patients. So it's very feasible to do this study in Tata Memorial Hospital. Let's say that now I am sitting in another center, which is in let's say is in Kerala. where head and neck cancer and the tobacco chewing is nearly literally no there. I don't even see 100 cases of head and neck cancer per year. The center is small. Overall, it says only 2,000 patients of cancer to cumulatively, and only 100 patients are coming. Out of those 100, only 40 patients are of stage 3. Now to recruit 400 patients, it's going to take at least 10 years if I recruit every patient which comes, which is not possible. Every patient is not going to give consent. So which means, so that is where the feasibility question comes into play. And that's the reason why you meet the statistician first and see whether this number which you're going to get is going to be feasible in your hands or not. Are there any questions on sample size, or we go with the next question which has come?
Or I can give some more point on that in continuation with Dr. Vijay's point. So you nicely mentioned about that type 1 and type 2 error. So let me tell you why it is required to consider the type 1 and type 2 error. Because see, as Dr. Vijay already mentioned, that feasibility of a study. See, why you are conducting a study and what is the importance to conduct a study and getting the results. Because every time you conduct a study, we're trying to understand what in reality in this population in large, or in basically based on the results of a study, we are going to generalize the results for entire populations. So that is the fundamental objective for conducting any study. Now it's true that every time you conduct a study, get an results, and based on the results, we are going to generalize that result for entire populations or prescribing that things. So there is a certain chance that whatever results we are producing, that might be some extent wrong. And to address that wrong or mistakes, this type 1 error and type 2 error stand basically to justify that mistakes. How these mistakes can come? Let's say you are getting an inference or results that, okay, my treatment, palliative treatment, or any effective therapeutic treatments is working well. So you are going to take a decision that this is with respect to the existing therapy, this new therapy is working well. So in reality or in general population level, it might be wrong. So it is not effective. Or it may be more effective that you are going to say. So in that way, so results can be merged in two directions. Wrong can be happening in two directions. Either you are saying it is effective, it is not effective. In reality, it is not. It is really not useful or effective, but you are claiming it is effective. Or vice versa, you are saying it is ineffective, but in reality, it is really working. So both the way it can work. So address this both mistakes or errors. This type 1 and type 2 error stands over there. So it's always the hypothetical numeric considerations being taken, and the reasons or definitions Dr. Vijay already mentioned over there. So every study should come with these two components for sample size calculations.
Yeah, Vijay.
Any doubts up till now?
So I just wanted to ask you, because we always say, as you have rightly mentioned, that you have to have a sample size, and you cannot complete, that is incomplete accurate. And I think many of the times we say the drawback of this trial was it was an incomplete accurate. Now the thing is that many times if you are doing an interventional trial, there are two arms, and many of the times we see that there is an exceptional result what you have assumed, and one arm you have to stop because maybe of the toxicity, or other arm is too superior that ethically you cannot offer the first arm. So in that, when you terminate that arm, does that affect really sample size? Or when you do statistical analysis and how to interpret it, that trial means, do you think that can affect the power?
So Atanu, you got the question?
Yeah. So
yeah.
See, as you mentioned that I think you are talking about some prospective trials, right?
So he's talking about a prospective randomized study.
Right, right.
And
Yes.
Two scenarios. One scenario, the experimental arm had a lot of adverse events, hence the study was terminated. Second, which is okay because it had a lot of adverse events, so it doesn't have much implication in practice. The second is actually a scenario in which the experimental arm was too good, and then the DSMB asks you to terminate the study and do an unplanned interim analysis. On the basis of that, it's concluded that the experimental arm is superior. So he wants to know how to interpret these two results.
Right. So, see, whenever you submit your proposal for institutional ethical committee for approval, so they always ask for, particularly for prospective randomized control trial, they would always ask to have the provision for interim analysis or DSMB board declarations or their report. So these interim analysis give us the provisions to conduct a study in between and get the results. And as you mentioned that you are expecting that this experimental arm is very much toxic, so you are not in a positions to continue the trial. So in that sense, definitely the interim analysis would support us and to get the results and get the earlier remarks on that. So based on the interim analysis report, we can stop the trial. And secondly, it might happen that your trial experimental arm is very much superior, so you don't bother to give this existing arm to the patients as a control. So you want to stop the trial. So both the cases, the interim analysis is safe to us, but in terms of the sample size calculation, what is your fundamental reason for this question would be what I guess, that what is the provision for interim analysis? So interim analysis taken care such a way that the power of a study should be untouched. So if you conduct a study, let's say plan a study for 500 patients trial, and you consider that power of a study as 80%. So even if you conduct the interim analysis, your power will remain same. It would be remain as 80% power, but there would be some compromise on the alpha, or that is called alpha spending function. So basically the type 1 part will be compromised. So and that with this less value of alpha or spreaded function of alpha, that is we are going to conduct that interim analysis report. So interim analysis is a byproduct of your entire sample size calculation. So when you are going to calculate the entire sample size, by default you are going to get this interim analysis power, and that's always been mentioned in this report, that what should be the interim analysis power when you can conduct the interim analysis after having what sample size.
Yeah, so well, I'll just draw a diagram and show you how this actually happens practically in a study. Hello, Atanu, I'm audible?
Yeah, audible.
So there are two types of way you can stop a study in between.
But I can see your board, I guess.
Yeah, so focusing now. Yeah. One is you have a planned interim analysis. And we'll spend next few minutes talking about planned interim analysis. So I'll give you an example. I'm doing a study which is as 1,000 to 1,500 patients recruitment. And it's a long time the study will go on. And I want to give it the chance that if the experimental arms actually does very well, I want to stop the study for efficacy. It can be opposite also. If the arm is not doing that well, I want to stop the study for something what is called as futility. Futility means even if I recruit the whole sample size, it is not going to be unlikely that the experimental arm is going to become a superior arm. So I'll show you how you do that. There are multiple ways of doing planned interim analysis. So the basic idea is like when you take type 1 error, you put your, as Dr. Atanu rightly pointed out, power remains the same. What changes is your alpha. Let's say that type 1 error we have taken as classically as 5%. And there are multiple methods of doing this. One method is where you actually divide this alpha by the number of interim analysis you are going to plan. Let's say that I am going to plan one interim analysis in between and one final. So I would interpret the result at this value. What does that mean? So simply, let's say that I'm doing a study of 1,000 patients For the final analysis, I required 800 deaths to be happening for the final analysis. But I wanted to analyze at 400, and I have planned this interim analysis, and my statistician has already given me with this method that, okay, you will do the analysis at 400 events, but then the alpha needs to be, so I would stop the study for efficacy if the alpha or the p-value falls below this levels. This is a very old method and the most, what you could call a rudimentary method. Nowadays, most of the people would use what Dr. Athanwat said was, one is O'Brien-Fleming method. So these are methods, these are statisticians which have given the methods for what is called at how to divide your alpha if you want to do an interim analysis. And there is a group sequential design method. So what happens in this method is, so if you go back to your MBBS days, your p-value actually corresponds to something called Z. Do you remember Z? So if you remember, we used to learn about a Gaussian curve, and this Z is equal to 0, and then the Z value keeps on increasing positively on this side, keeps decreasing on negatively on this side, and there is one value of 1.96 which corresponds to 0.05 p. So there are Z to P tables available. Now why I'm telling you this is, when you look at GS design for interim analysis, you will get a chart like this in which there will be number of events written here, which will go from 0, because at the start of the study, obviously there will be no events. Events means if your primary endpoint is overall survival, death is an event. If your primary endpoint is progression-free survival, then progression or death before progression is an event. If your primary endpoint is, let's say, larynx preservation rate, so in that, death will be an event. Disease recurrence will be an event. If you had to do, if the patient requires gastrostomy for 2 years or more, that also is an event. If the patient's larynx is dysfunction and requires aspiration, that also is an event. Point is, event is like a big name, and under event you can have multiple, what you can say, events, sub-events kind of, which would say that. So we won't fall into that. From 0 to this, and let's say this is 100 where you wanted to do the final year. The Z value will be such that if you see the graphs, it will be like this most of it. Which means if you, let's say we have done planned 3 interim, 1, 2, and the final is here. So higher the Z value, the lower the P is required. So, and this will, don't bother about how the Z will, that your statistician will do. But you need to understand that if at 100, if I am doing this analysis, let's say at 25 events, 50 events, and finally 100 events, there will be a predefined Z value which will be there. If that Z value is, if this Z will translate into a P value, because it's a higher Z value, the P value will be smaller, 0.00030 and then 6. If when I do the analysis at 25 events, if the P comes below that value, then I would say is that the study should be stopped for efficacy. So for example, if let's say at this stage, the P required for 0.006, but I get a P which is 0.008. This looks significant, but you cannot stop the study for efficacy because this is higher than your predetermined yield. Why are we doing this? This has been done because when you do a small sample size, 1 or 2 events on this side or that side can sway your results. So you want to be very sure that when you're taking decision on a small sample size, the results are absolutely significant. Okay. Now, as I brought this, we are now talking about only our planned interim analysis. I'll come to unplanned interim analysis after this. There will be a Z curve like this also. Now this Z actually is for futility. So for example, you do this and this also is giving you a P. If your Z is coming below this, which means you can actually stop your study. Whatever happens, this study is unlikely to become positive in future. Very few people do this, stopping for futility. And
When you plan your study, it needs to be pre-planned whether you want to stop only for futility, only for efficacy, or both for efficacy and futility, because the formulas differ. And this has implication on sample size. If you add interim analysis, your sample size increases. If you don't have interim analysis, the sample size is easy. If as a clinician, you are going to plan your first study, I would never advise you to put interim analysis. Because when you put interim analysis, it also means you need to have a thorough check over the number of events which are happening. You can't once in a year say, let me see how many events have happened. Every 2-3 months, you need to keep a check over the number of events which are happening. So I hope this answers the planned interim analysis. Atanu, anything you want to add?
Yes, so you nicely present the graphs. One thing I just want to add, in the graphs that you are having this, that triangle shape. Within the triangle, if the p-value comes within the triangle, in that means you are okay to pursue the study. Irrespective, yes, within the triangle. If it is a beyond the triangle upper value or lower line value, then you should stop the study and take a call on that. So that's that. In simple way, it is
telling you that when you do this analysis at this first day, you can get a value above this. If the value comes above this, you stop for efficacy. If you get a value below this, you still stop the study for futility. If you get the value between this, which means that you proceed and keep recruiting the study and then do the analysis after that. So this is about planned interim analysis. What I'll do is we'll talk about unplanned interim analysis, where your so this is unplanned interim analysis. What can happen is when the study goes on, you keep on sending essays to the IEC and the DSMB, and the DSMB may feel that your experimental arm is having a lot of events, and it may do a monitoring, and it depends upon the wisdom of the monitors and the IEC, and they may just ask you to stop the study. Now, when you stop the study for, let's say, for adverse events, how do you interpret the results of the study? We'll see that. The second can happen is, when they come for regular monitoring, they can see that observational arm, the patients are having a lot of events because of no treatment. Or like I'll give an example. I'll give a real life example. How many of you have heard about Dr. DeCruz study, N0 study? So that's a shame that only 3 hands are there. That's the only New England Journal publication from India. So the study was in head and neck cancer patients who were T1, T2, N0. At that time, around 15 years back, there was a divide whether they do neck dissection, selective neck dissection, or to keep these patients on observation. So the study answered this specific question: one arm selective neck dissection, one arm observation. And the study was actually monitored by the DSMB of TMH and was told to be stopped because the arm which was on observation, they saw that a lot of recurrence were happening in that arm. Now, what to do if such situation arises? So you had planned something and the DSMB actually tells you, okay, now that this has happened, you stop the study. How to interpret the results at this time? So at that point, we again go back to this graph. You can actually draw this was where the final analysis was supposed to be done, and there's a Z value at the number of events. There are softwares available. GS Design has Overall Plumbing. You can actually, now the number of events because the DSMB has told you to stop the study. So you can see what is the corresponding Z and what that translates into. And if the P is below this, then you actually say that the study is positive or no. The problem is because this is unplanned, this was not taken into consideration when the study was designed and calculated. This is actually a big gray zone area. Some people may say that, okay, it was stopped because it was stopped and it was not supposed to be recruited. even a P of 0.05 or below, if you get, you should take it positive. But the purist will say that the corresponding Z should have been seen, and that should have been converted into the P value. This P is definitely going to be below 0.05, and that P should have been reached for you to stop. So that's why unplanned interim analysis is never a good idea. The third scenario which can happen is, which Dr. Ashe was hinting to you. There's a study going on and it was supposed to go on, but for some reason it is not recruiting. You don't know the reasons, whatever be the reasons, and the PI gets frustrated and he stops the study. Now we'll ask Atanu what to do in that situation. Atanu, study.
Yes.
So it does not get recruited. The PI says, I have done with it, 10, 12 years have already gone. Let's say 700 patient studies, 400 I'm done with the recruitment, I'll do the analysis. How do you interpret the P in that?
Yes. So one thing is that for unplanned study, one thing we always miss, and that after I come to this, how we can pursue this once we are having already spent 10 to 12 years and we are having 400 patients, and what to do. See, for one thing is that for one good thing with this proper plan in interim analysis for prospective randomized controlled trial is that we always keep it in mind that this both the groups between the groups the patients are randomly allocated. What does it mean randomly allocated? Means in terms of the age, gender, disease prognostic status like stage 3 and stage 4. Both arms are having equal numbers or percentage of patients, and thereafter we are going to conduct that interim analysis. That need to be fixed always. But what happened in unplanned study, one catch area is that sometimes it might happen that one arm is having very inferior type of patients, mostly 80%, let's say 80% are stage 4 patients and 20% are stage 3, and in another arm it is around 60% stage 4 and 40% stage 3. So it might happen. So in that sense, ideally they are not comparable because these percentage of stage 3s are not equal, or stage 4 are not equally distributed between these two groups. So in that sense, it is always need to keep it in mind while we are going for unplanned study that percentage of group wise or stage wise, gender wise, age wise, these groups are equally distributed. So that's always a catch area, and sometimes we do miss and get that different results and make an interpretation. So one thing is that. Secondly, as you mentioned that that if you already spent 12 years and you are supposed to get 700 patients and 400 patients are there, what to do? For that, see, sample size determination is not way to pursue because you are already having data. Sample size determination is required while you don't have the data. You are going to make a study or plan a study in future directions, but once you are already having the data, so there is no sense to calculate the sample size again. What is only required is to understand based on your data or event rate, because if you are having 400 patients recruited, obviously out of that 400 patients, many of the event you may accept. So 400, let's say 100 patients were having event. So event could be anything, death, relapse, progression, whatever the event you are defining in your study, that could be there. But let's say out of 400, 100 events are there. And in these 100 events also separated into two arms, like one arm is having 70 events and another arm is having 30 events. So you are always already having the data, having the results of the data. Only you have to do is this calculating the power. So basically, whatever we are doing the sample size calculations, we are in futuristic way, we are going to calculate the sample size. But once you are having the data, we retrospectively, we are going to calculate the sample size, or basically having the sample size, what is the power we are going to determine. So another way for planning a study, sample size calculation, we are calculating sample size by putting this power of it as an ingredient. But when you are having the study data, then based on the sample size, you are calculating the power. So basically, it should be calculation of the power of a study.
Okay, so
Dr. Vijay, now if
yeah,
you please, if you add in.
Yeah, I'll simplify further. So there were two issues which she brought on, and I'll explain you there on the graph. One issue was, though it is a randomized study, when you do an unplanned interim analysis, there can be differential prognostic factors between the two arms. And now why does that happen? Because when you do randomization, the randomization is factored in such a way that when you complete the sample size, the prognostic factors for which you are stratified, they will be equally divided. I'll give you an example. Let's say I'm planning a study of lung cancer and I am doing a stratified randomization. Okay, and my block size is 6, and I'll explain what is 6 block size means. And let's say that the things which I am stratifying the patients is for age. I'm saying elderly, non-elderly. Okay, it's a EGFR positive study. So all are EGFR positive, but I'm stratified for 19 versus 21. These are two types of EGFR mutation you can get. I'm also stratifying for ECOG performance status 0, 1 versus 2. We all know that in lung cancer, brain mets has a poor prognosis. So we are also stratifying for brain mets present and not present. Now these are the number of stratum. Now how many stratum the patient is going to have? Any idea with this number of stratifications? Okay, let me show you. Age, elderly, non-elderly. Okay, in elderly, let's focus on the elderly side. It can either be 19 or it can be 21. Okay, in 19 it can be either be PS 01 or 2. In 21 it can be PS 01 or 2. Okay, in 01 or 2 it can be either brain mets yes or no. It can be brain mets yes or no. It can be brain mets yes or no. It can be brain mets yes or no. So in elderly itself, this is 1, 2, 3, 4, 5, 6, 7, 8. Similarly, will be on this side. So there are actually 16 stratums. Now in each stratum, let's say the block size is 6. The block size can be 4, 6, 8. I'm giving a 6. What does that 6 means is, after 6 patients get recruited in that block, so elderly with exon 19 with PS 0 to 1 without brain mets. When 6 patient gets recruited, in both arms there will be 3 and 3. The sequence in this 6 can be A, B, B, B. It can be AB, 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 BA, 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 or any kind of combination which allows you after 6, 3 in each arm and 3 in each arm. Now, when the study is supposed to recruit completely, that is the time when this will get A. Now, understanding in 16, you may have discrepancies. Some patients A would be more, some B would be more, and there is a good chance that when you stopped in between, what he said, that the prognostic factors will be unbalanced between the two arms would arise. So that's one point you understood. The second is, he very nicely touched upon that. Let's say Dr. Ravikant wants to do a study, and that's a study involving use of scalp pulling machines in prostate cancer patients because they are worried about the hair. And he's giving docetaxel to them, and half of them are getting scalp pulling, half are not getting scalp pulling. And after it's 1,000 patient studies, after 400 patients are not ready to get recruited because everyone is saying that, okay, the hairs are been preserved, and no one wants to get randomized to the arm without scalp pulling. Unlikely situation to come in Muzaffarpur, but let's assume that this happens. Now, the thing is, now he can't do anything. He just stops the study after 400 patients. He can still use the P, which was planned of 0.05. But what he loses is the power. What he loses is the ability to see whether there are the chances of false negative in this situation increases dramatically. Okay, so the chance of false negative results in there. So if you have a study which has been stopped for logistics issues and it has significant results, it still is okay if the prognostic factors are balanced between both arms, because that is one thing which is likely to come. If you have a study which is stopped in between, and you see that sometimes they say it was going towards statistical significance. There is a likelihood that there might be a false negative results which has come because of less recruitment of patients. I hope, Asha, that answers your question. Okay, so we'll move on with the next question.
Ask this next question in this context only. That can you change the sample size midway between the study? Because your old sample size calculation was based on some XYZ data in the literature, but now you have a new response rate as per the new studies. So can you revise your sample size midway between the studies?
So, Atanu, I'll reframe the question to you. And this actually has come from Dr. Venkat from Adiyar. I know the question from where it has arises. A sample size was done based on Western data. Okay. And the study has already started. But in between, a retrospective analysis was done at the center. And they now know that the standard arm sample size. So they had assumed 5-year survival of 30% in the standard arm, but the retrospective analysis actually suggests that the 5-year survival is only 10%. So what to do when you come across this kind of things? Can you revise the sample size when the study is ongoing? That's the question.
Yes. So yeah, it could be happen, and it can be answered. It can put us in two directions. One thing is that based on the updated informations, are we going to change our outcome of the study or not, or primary objective of the study or not? It might happen that since you calculated the sample size or planned the study based on the Western data, now you are having your own center data, and based on the own center data, you are going to recalculate the sample size. In addition to that, you also might fine tune your study objective or primary objective, I would say. If you are shifting your primary objective from the earlier study objective, then it is better to consider it as a new study and put it as a new study proposal and calculate the sample size as a fresh and perform the study. But in that case, if your study objective is remains same, you are just using the updated informations to calculate the sample size. And as you mentioned that it is your own study center data. So we always prefer to have the study samples data, because the informations that we need to calculate the sample size as nearer as possible from our real life scenario. So as you mentioned that your study data is from your center itself. So it is always preferred to consider your own center data and recalculate the sample size based on the updated informations, and it's very much okay unless and until you change your study objective or study design. And for that purpose, you might require to approach to IEC to resubmit your modified proposal or amendment proposal with recalculated sample size. But I think that is okay to pursue with that.
Okay, so I hope that answers the question. Everyone understood that? So the thing is very clear. If your endpoint was 5-year overall survival, you want to keep the same endpoint, but want to revise your calculation, you can do that. You need to approach your IC with the. But if you're going to change your endpoint, let's say the OS is going to become DFS, then it's better to submit a separate proposal. And it's very important that you have a look at your own data. And I'll just tell us a experience from our side, and my neuro team is not here. We did a study of repurposing of mebendazole in glioblastoma, where we were looking at whether addition of mebendazole to CCNU leads to an improvement in outcomes or not. The success rate of the study was that at 9 months, the overall survival should have been above 55%. This was taken from a European study called BELLO, which was done by Juan Martin Vanderbet. And this was used. When we analyzed the data, after obviously we did the phase 1 for mebendazole and then we went ahead and did the phase 2. We failed miserably to achieve this. The 9-month overall survival in the CCNU plus mebendazole arm came out to be 47%. And when the study was actually ongoing, we used to use CCNU in daily practice. And when the study was actually ongoing, it was a feeling among the investigators that the mebendazole addition was working well. But when we analyzed the data, it didn't seem so. And hence we actually went to see why did we got these results. What we saw was the BELOP data in relapse glioblastoma recruited only PS0 and 1 patients. Now, those of you who look at neuro will know that in GBM, PS2 and 3 are actually the majority of the patients. Very few patients are PS0 and 1. But that's what the BELOP study had done. When we had actually written the protocol, we had allowed the protocol was by the name of reverse swing. We had allowed PS0 to 3. And nearly 35 or 40% of our patients were PS2 to 3, with 3 accounting for around 20% of the patients. Now, whoever knows a bit of oncology would also know that if you have this group of patients and you are comparing the outcomes with this is like not apple and oranges. This is actually pea and a football. And if you restricted the analysis in our study to 0 to 1, it actually crossed this margin. So I always feel that that was some amount of inexperience from my side when this study was planned in 2015 and 16, where we should have looked upon our own data at what is our distribution. Because of this, we had to conclude in the paper, because this was pre-specified that mebendazole does not work with CCNU in the whole cohort. However, Lancet actually allowed us to put a line that it needs to be explored further in PS0 and 1. But I'm very sure that if you would have, because when our data, Dr. Nandini is actually downstairs, when we saw our own data, when there were similar PS2 and 3, our 6 month, this is 9 month, our 6 month OS was only 30%. And this was 600 patient data. So if we would have this value, this definitely would have come as a positive study. So it's important, first of all, that when you do the studies, it try to get the data from your setup, either your institute or institutes which have similar setups. Second is, it's important that if you get like Dr. Venkat got here, in between you are seeing that your assumption is something different. It's better you change the sample size if it requires to do so. Any questions? It's okay. You can ask any questions you want. Yeah, mic le lo, mic le lo.
Are all unplanned interim analysis underpowered, or they have not reached?
By definition, yes. Because when you say type 1 error this, type 2 error this, and you get a sample size is this, if you stop before that, yes, the power will be less. Okay, so that is yes. So you can't compensate. So you actually see, you can't compensate anyway under power. You can continue with the study if you do an unplanned interim analysis. If your IC asks to have a look at the data, what you lose is you now need, so when you do, let's say there's no interim analysis. Your P at the end is 0.05. You do one planned interim analysis, not unplanned, you allocate some P here. So your final P is actually less than 0.05. And that would be depending on the complex calculations the statistician would make. Let's say that it is 0.04. You did an unplanned interim analysis, 0.04, and the final P, when you did the analysis came as 0.045. By definition, the study is negative.
So,
yeah.
If the power is it has not reached, then why do the unplanned interim analysis?
So unplanned interim analysis is never planned. Unplanned happens because something happens. So for example, there were the three situations which can happen is one, you report adverse events to the IEC, and IEC in its wisdom and the DSMB in its wisdom feels that too many adverse events are happening. So let's have a look at the data on the basis for safety. The IEC does a monitoring of your study, which regularly, 1 yearly, 2 yearly, they keep doing. They feel that as in N0, in the other arm, standard arm, too many events are happening. So they are again doing it for patient safety. Third is like a situation like say Manu is trying to do a study in Kerala. At that time, 5 centers say, okay, we will collaborate. And then he is the only person who is doing the study, which is a very common situation in India. And he can only recruit 400 patients. The sample size was 1,000 patients. He said that it is impossible for me to continue. Funds are not there. He stops at 400. So no one wants to do an unplanned. Unplanned actually happens because of some of the other things which happen. And quite a few studies have unplanned analysis.
One thing is that very important to clear is that this intention to conduct any interim analysis is basically protect the patients. So something miserably going wrong, not going wrong to the patient, that is need to be only reason to conduct any interim analysis. But if you talk about we want to conduct the interim analysis to publish the data earlier, no, that is not going to work, because always the study strengthening, I would not say only the power, I would use the study capacity is not good enough to publish it or complete it unless and until you complete the study with this enter sample size. So very important point is that we should conduct interim analysis only to understand something wrong is happening to the patients or not, or protect the patient. That's all, not for the study publication purpose.
There's a question. Pritesh, take the.
How much importance should we give to unplanned, or how much importance should we give to a subset analysis which was not predefined and done after the study? So a lot of studies which are negative in the which result negative, but they later on say that we did a subset analysis in this group and which showed that there was significance. So how do we take that?
So for all practical purpose, not pre-planned subgroup analysis is hypothesis generating, which means, let me tell you that I did a study of in adjuvant, I'm giving metronomic versus not metronomic in T3, T4 patients of laryngeal cancers who have undergone CTRT. I do the analysis, the study comes negative. I see that in patients who have extranodal extension, there is hope that addition of metronomic might improve the outputs, because that's a worse subgroup population. This is hypothesis generating. This hypothesis needs to be tested in another study. I cannot label on the basis of this study that this is, but this is, sometimes what happens is there are pre-specified subgroup analysis which are written in the study protocol. So it's always important that when you read studies which define treatment, you do not only Anbarsan, have coffee and come in. Go have coffee and come. Yeah. You do not only do read the paper, but you also read the study protocol, because it's the study protocol which is the most important document. The study protocol actually gives an idea of what the study team was thinking when they were planning the study. And in that, if they have put a predefined analysis, okay, this we are going to study. So the two things needs to be there. You need to predefine, and you also need to define the direction, which means that we think that in this would be improved to a larger extent or something of that sort. So in those things, you can take those predefined analysis, subgroup analysis, they predefined the protocol and even the direction was maintained, because if they were able to tell the direction way back 4-5 years, which means there was a biological rationale for doing that predefined analysis. So for example, when the IPAS study came first, IPAS is the study by Tony Mock, which established Jeftinib way back in, it's a New England Journal in 2007 or 8. And he didn't take EGFR mutated patient. He selected patient who had clinical features who are likely to be EGFR mutated, a female, a non-smoker, and such kind of patients were selected. There was a predefined, planned subgroup analysis of EGFR mutation versus no mutation, which was defined. And that we all know we started using Jeftinib after IPAS scheme, because so you need to have this predefined analysis, subgroup analysis, which is then you need to give the direction also. Now, the question can come, when you do such subgroup analysis, how do you know that there is an interaction between the study arm and what you're looking? So let's take the example of EGFR mutated here. Atanu, you want to add anything?
Yeah, so basically, in continuation to your remarks, so see, study results can be separated as two way. One thing is the confirmatory study, and another thing is the exploratory study. So confirmatory study is basically based on your primary objective of your study, and that's why you calculate the sample size and defining the protocol, and based on that you are making the comparison, getting the results. But in addition to that, with this hypothesis given study or confirmatory study, during the data analysis you can come up with different subsites or subgroups and can get the results. Are one subgroups are having different result, better results as compared to other subgroups. So you can eventually you can invent, okay, this is EGFR positive, this is male, and thereafter age below 30 years. So these are going to be having very effective, or outcome is going to be very exciting. But thing is that these are all exploratory study. They are not adequate in terms of the sample size calculation, in terms of the power. They are going to give you some light or path to go forward. Next level, if you want, you can conduct some study dedicated to with these subgroups. There is having, let's say, EGFR positive, male, 30 years below, and any other way of you want to conduct. But don't jump to a conclusion by looking on the exploratory study or exploratory subgroup analysis results, and don't make a conclusion on that. Sometimes there is a people having tendency to put more light on the subgroup analysis because their main primary outcome is not being done, or results are not coming as expected. So they gives much trace on the subgroups part and give more presentation on that, but never buy these kind of product, because these are not the real study driven analysis. These are all exploratory study analysis.
So are the pre-specified subgroup analysis can be the same as that of a stratified analysis? For example, age. We haven't defined pre-specified subgroup analysis based on the age factor, but we have stratified age more than 65 versus less than 65. So are they the same? Can we say that these are pre-specified subgroup analysis, or they are different?
They're different, Anil. You need to specify which before which you would be looking at. Normally what we do is, whenever we do the forest plot, we normally tend to give the forest plot for the things for which we are stratified, but it need to be pre-specify that you will do for this. I'll give you one example what you would look in when this such kind of subgroup analysis. What we do is called as interaction testing. So you are seeing whether the arm has an interaction with this factor. And let's take Jeftinib as the arm, and EGFR mutation positive and negative, what was seen by the famous Tony Mock New England Journal publication. And you can have what you're looking is whether there is a difference in the way the group was divided on this biomarker, whether they behave differently. The difference in the behavior can be two ways. Either the benefit was more in one group versus the other. Both benefited, but one benefited more than the other. This is actually for those of this is a snapshot of a forest plot. And what I'm highlighting is the hazard ratio. This is the median hazard ratio. This is the 95% confidence interval. This is unity 1. So anything before here is better for the experimental arm where we had written Jeftinib here. Anything on this side is better for the chemotherapy, what I've written chemotherapy. Clear with this? So what has been shown in this graph is there is one subgroup X and one subgroup Y. This has a better hazard ratio, 0 is here, than this. So there is benefit in both because this lower limit of 95 confidence interval is better than A. So there's benefit in more, but it seems visually that X has benefited more than Y. And you would see these comments coming a lot of time, Pritesh, that in this there was more benefit. Let's see how do you actually statistically say whether there is more benefit or not. In this, they would say, okay, there is mutation positive. There is not much benefit in mutation negative with Jeftinib. How do you actually conclude that this is there or not there? You need to look at the interaction testing p-value. If the interaction testing p-value is below 0.05, which means this difference actually exists. If it is not, then this difference actually doesn't exist. Okay. Now, sometimes one more thing which you'll see is, I'll just put it here, that the graph is like this, but this has crossed. Okay. And then people will say that the unity has been crossed. Now understand that this is the confidence interval. The confidence interval is a function of two things. It's a function of median, but is also a function of the sample size. Let's, for example, I do a study in head and neck cancer, and most of the head and neck cancers are male. Females are a bit less. In most of our studies, oral cavity, you'll see 80-85% are males and females are less. And let me try to draw another forest to explain this point, which is an important point as clinicians to remember. Male, female. Let me say that this hazard ratio came here and female it slightly came here. This can also happen if, let's say, you are looking at brain mets yes versus no. Brain mets yes has poor prognostic factor. So the increment which you get with the intervention arm may not be that high. Brain mets no has a good prognostic factor. The increment which may get may be high also. So this is also depend upon a function of prognosis. So interaction test also looks for that. And let's say that 85% of the patients are males. So obviously the confidence intervals are going to be very tight, which means they should be narrow. You're getting me? Okay. Now, let's say the study was of 1,000 patients. So 850 were males, 150 were females. Obviously, the confidence interval for 150 is going to be broad. So you need to also look at this. And that's why that interaction testing value remains important. Now, why is the confidence interval a function of samples as anyone? So whenever you remove confidence intervals, you actually look at standard errors. Standard error is inversely proportional to the sample size. So the higher the sample size, the standard error is going to be less. Obviously, the confidence interval is going to be small. So just remember this thing. You will get shorter confidence intervals if the sample size is high. Okay? Are we clear? And so, yeah, just a second. And hence, for such things, you always look at the p-value. Yeah. You can wait.
So, but interaction testing p less than 0.5 is also only hypothesis generating, no?
So what you are saying is correct. If it was a post hoc analysis, yes, it is also hypothesis generating.
But but that sample size is never powered to answer that question, no, sir?
Yes,
So
that's
does
correct.
interaction testing help us in that process?
No. So I'll tell you what interaction testing helps me. Let me take this example again. Let's say I was Tony Mock when I planned the study. I have not specified this pre-specified analysis. So this is now a post analysis. Now I want to see whether Jeftinib actually benefited more in EGFR mutation positive. And my thing is, okay, if it is benefiting, I'll do another 600 patient randomized study of EGFR mutated. So whether to go ahead with that study or not, whether this hypothesis actually exists or not, I will do hypothesis testing and I'll say, okay, I need to go with this. But Tony Mock was smart. This was a predefined, pre-specified analysis, and he had also given the direction that it would be better than the EGFR negative because biologically it seems so. And he did this. Now, because of this interaction testing, it actually got, it actually got started to be used. So see, we must understand that as clinicians now, we have never been pure with statistics. Many of the subgroup analysis we have actually incorporated in practice knowingly or unknowingly. For example, extranodal extension and margin A. If you look at the RTOG study and the URTG study, one study had only these factors, the other had a lot of factors. When the combined analysis was done, we only took these two factors because their P was had a major benefit. So we always have been using such things. Second is a good example. Those people who have good thoracic units will tell you that if lobectomy can be done, it's better than CTRT. The SPUTE trial, which actually gave these results, was actually this was a subgroup analysis. Overall, there was no difference in outcomes, whether after neoadjuvant chemotherapy you did CTRT or you did surgery. This was a subgroup analysis. So there is a sense of what I would say is one thing you look at statistics, but one thing is pragmatic use of the data also. Yeah, like for example, we'll always say that you need a non-inferiority trial to change the standard of care. We all use gemcitabine cisplatin in urinary bladder in metastatic. Go and read the study in which it was compared with MVAC, not DDM. In the MVAC, it's a palliative setting study, came way back. It was actually to show that gemcitabine cisplatin would be superior than MVAC. It didn't prove superiority. Statistically speaking, was a negative study. We shouldn't have been using gemcitabine cisplatin. But the side effects with gemcitabine was so less than the MVAC, and the data showed that the curves were on top of that. We just accepted that gemcitabine cisplatin could replace MVAC. So what you're saying is correct. Many times clinicians do take these judgmental calls, which yes, that we need to know when we take this judgmental calls, what are the pros and cons of taking those judgmental calls.
Just one more doubt, sir. What we mean by pre-specified analysis, does that have an implication of increase in sample size?
So I'll tell you, when we say pre-specified analysis means, when you wrote the study protocol, you would have defined that I'm going to do this analysis. And I'll tell you why that is done. Let's say I do analysis of all patients in the study and say I'll compare all patients whose name starts with A versus non-A. Then I'll do a comparison of B, non-B. I can have 26 analysis. A to Z is there. So A, non-A, B, non-B. When you do roughly 20 tests, one will come positive because that's the false positive rate you will have. That's why you need to pre-specify that I'm going to look at this. The reason why I'm going to look at this is the biological rationale. And with newer targeted therapies coming up, with newer PDL1 studies coming up, you will be seeing this more and more. Now, I won't add more complexity. There is something also called hierarchical analysis, where you would start with one. If that is positive, you will go to next. If that is positive, you will go to next. And good example is Keynote 048, which is a study of chemo plus cetuximab versus chemo plus pembrolizumab, which first tested in PDL1, it's a CPS actually, but let's take PDL1 20% or more positive, then tested in PDL1 1% or more positive, then all patients. So different, there were actually 12 and a pre-specified hypothesis which got tested in this kind of sequence. We don't fall. That is actually higher level of statistics, and that would take a lot amount of explanation also. But the thing is, if it is pre-specified, there is a thought process behind that, and most of the statisticians and clinicians would agree with. We'll go to the next question, Ashay. What's the time?
Is it possible to do a 3-arm clinical trial? There is 1 standard arm versus 2 intervention arm, superiority design. Power to show superiority of interventions over standard arm and 1 intervention arm over another.
Yes.
What the question? 3-arm study?
Yes. So, yeah. So before that, I would like to say something about this conventional 2 arms and in terms of the 2-arm studies with, in terms of the overall survival or progression-free survival comparison. But anyway, as you already said, so let us give some picture about that. What happened when you conventional make the comparison for these ways or PS-wise comparison. So yes, we consider that as a reference arm, as a control group or existing therapy as a reference group, and with respect to that, another groups we make the comparison. So comparison can be 2-way, can be performed in terms of the, I'm now coming in the area of this survival analysis or the oncological trial, where outcome can be defined in 2-way. One thing is that in terms of the percentage, like event rate, like death rate, like progression rate after certain time point. This is the one way we always capture the outcome of interest, and based on that we calculate the sample size. Second way is to consider the median duration of survival or median duration of progression-free survival, median duration of relapse-free survival. So these are the 2-way. So irrespective of the way it is going, means percentage or the event rate wise comparison or the duration of median survival comparison, both the way we consider the existing arm as a reference arm, and with respect to the reference arm we try to find out what happened or what is or anticipated outcome for the experimental arm. So this is the way. So it is basically one hypothesis and one with this reference group with respect to the experimental group, we make that thing. That's the way the 2-arm comparison makes. Now for these 2 arm, we can make 1 arm as existing or the reference or control arm, another is the experimental arm. But if you truly think that 1 arm and the existing arm or reference arm could be another new treatment arm, that is also fine. So both arm can be considered as experimental arm or running experimental arm, I would say the word. Both arm can be considered as the running experimental arm, and we can make the comparison and calculate the sample size, conduct the study. But while you are talking about 3 arm, so in that sense, we have to consider these 2 arms, means 1 arm as a reference category, and with respect to that 1 arm, first, second arm and third arm, both will be considered the comparison. So now it's up to you which one out of these 3 arms, which one can be considered as a representative of the reference arm. Representative of the reference arm means that should be conventional arm or some extent the very minimal effective arm, or let's say very usual arm, therapeutic way to perform the treatment. If you're okay with the consider that one as a some so-called kind of reference arm, then obviously with respect to that arm, 2 other arm can be compared as, and we can very easily perform the study with the 3 arm calculation study design as well. Yeah, that is possible. In terms of the technical methodological issues, I think we need to have some mathematical algorithm over there to be kept in mind while you are performing the sample size and study design. But it is possible to perform with that. Yeah.
Okay. So the Atanu, can you show one sample size calculation? One of my observers is getting very anxious that there's no sample size calculation actually shown.
Okay.
And show one.
Okay, so just I was thinking to show some kind of thing. So, calculating sample size.
Give me 5 minutes. I'll explain them P0, P1 so that they know what it is. So whenever you actually go for a sample size calculation, you need to know, see, why are you doing that? You are doing it so that you improve the outcome. So obviously there will be something called P0. In statistics, P0 means what is the baseline outcomes. Let's say, sorry, I do only neuro, head and neck and lung. So my examples will be only from this 3 groups. And let's say that I'm looking at oral cancers, locally advanced oral cancers, surgery, radiation, CTRT. 5-year outcomes is only about 30%. 30% 5-year OS. Now, I'm impressed with the data of neoadjuvant immunotherapy, which has come in lung cancer, and the phase 2 data of Dr. Ravi Upaluri, which was presented in last year's ASCO, in which he did show that 2 doses of pembrolizumab given before surgery actually led to very good path CRs to the tune of 47%. And we all know that higher the path CR, higher the chances of survival. So I think I'm planning a study in which 2 doses of pembrolizumab given would lead to improvement in outcomes. The question comes, how much improvement in outcomes you want to see? So what you can do is you can actually go to the phase 2 data and see how much improvement it gave, and you can put that figure. Let's say that it improved by 10%, so I can use 40%. Sometimes, let's say that Manu said, okay, sir, we might do a study of 2 cycles of pembrolizumab and then surgery. But most of my patients can't afford full dose pembrolizumab. So he says that you did a study of low dose nivolumab and palliative. Why don't you do a study of low dose pembrolizumab in neoadjuvant? Now, I don't have much data about low dose pembrolizumab in neoadjuvant setting. So how do I select how much improvement in outcome needs to be taken? What I do in such situation is I go to a scale called ESMO, magnitude of clinical benefit scale. These are recommendations which are given by ESMO, which tells you that if you want to use an intervention, and it definitely would be recommended, they have categorized as type A recommendation, type B recommendation, type C recommendation. In palliative as 1, 2, 3, 4, and 5. Type A and B is for curative settings. For outcomes, which is similar to 5-year OS of this, how much improvement in hazard ratio needs to be there for that recommendation to be used in clinical practice. So I will actually take that shortcut and say that the arm which I'm going to use should give me at least the type B recommendation. There's no point in doing a study and getting a type C or type B recommendation, which as such I'm not going to use. So let me go plan it for type B recommendation only. And I see that hazard ratio and I get it calculated from Atanu for that. Type 1, as I told you, is false positive. So conventionally people will keep it at 5%, or what you would say at 0.05 would do the P. Type 2, you normally keep at 80 or 90. How do you choose 80 or 90? It actually depends upon how much money you have in your pocket and how much your funders are going to give you money. And it's as simple as that. It comes down to that. How much a 10% increase in the power will means 25% increase in sample size. So if you're someone like Anil who has IAEA funding behind him, you can go for 90% power. If you're Vijay Patil, for whom the funding has to come from ICMR, DBT, or begging around, he will go with 80% power. You also need to specify to Atanu how much long is going to be your recruitment period, how much long is going to be your follow-up period, and what are the chances of your loss to follow-up. The chances of loss to follow-up will come from your previous experience or doing the study. If you are a newbie, then it's better to look from your senior's experience, 10% loss to follow, 5% or 20%. Obviously, it's simple. More the loss to follow up, more the sample size would increase. And recruitment period and follow-up period, I'll come to one. Let Atanu show an example, and I'll show you how your recruitment period and follow-up period can also have a implication on sample size. Atanu, you show one calculation, man.
Yes, so I'm going. I hope you can see my slide.
Yes.
Yeah. So let's say this is one example I brought from that library called GS Design. It's applicable in R. So that Dr. Vijay already mentioned that group sequential study, and these packages GS Design is basically for group sequential design study.
Atanu, give me a minute. So what you're seeing here is actually a R portal. R has libraries and packages on this side. That is the command, and you'll get the output here. Okay, so you just enjoy it, how it works. This is the best form of sample size which you can get on our portal. And GS Design is one of the best softwares which is available for doing a sample size calculation. Atanu, please continue.
Yes. So just you have to install that package, or you can freely install this Art Studio, Art software. And nowadays YouTube, you can go and check how to install software and art software and packages. So I'm not going into details on that. So whatever the results are going to come, it is going to come here in below window here. So let's see. This is a syntax, only one line syntax you need to run. I'll explain what does it mean, each syntax meaning, and I'll run as well, so to get an answer. So this is n survival, small n, then capital S, then survival. So look, this R is case sensitive. So capital S means you have to always put capital S to put the n survival. So this is a function that these functions calculate this sample size, calculate the sample size. And for that we already discussed what is the inputs we need. So few of these things we already discussed, and few of them we will see here and we will explain. So these are the inputs we need to have to calculate the sample size, particularly while we are talking about in oncological trial, where our outcome is progression or death, look on the death rate or progression rate or relapse-free rate. So since we talk about the progression rate or the relapse-free rate, so always we consider the terminology called hazard ratio and hazard rate basically. So hazard is basically the death rate we are considering. So in mathematical books or statistical methodological books, people do considers the mathematically the hazard rate as lambda. So here you will see two values of lambda is given. One is called lambda 1. So not values, this is basically name. So this is lambda 1 and this one is lambda 2. This is basically talk about this one group, treatment group hazard rate, and it is anticipated that this treatment group, or let's say this existing group or the reference group or the control group, whatever you say, for that the anticipated hazard rate is 0.2, means 20% will die after certain time point or relapse after certain time point. So that is 20% is converted as 0.2, and that is been given as lambda 1. Similarly, another group that you are expecting that it is a better group, or it is basically the experimental group. So in that group, you define the hazard rate as lambda 2, or call the hazard rate for that group as lambda 2. And for that, you define that, or anticipated value for hazard rate is 0.1, that is mean 10%. But for the both group, existing group, that is for lambda 1, and experimental group, that is lambda 2, both groups, what you are expecting that after certain time point, what is the hazard rate is going to happen. So in that sense, both group has to pass some certain equal number of study interval. So define that study interval. I'll come this eta value later, but now so this study interval should be by and large in sometimes it could be in months, it could be in years, or it could be in decades. But for the timing, let's say it is, we consider it as a unit, could be anything, but let's say it's a study duration, we are going to consider as total duration of the studies as a 2 years. So these 2 years, TA stand for the 2-year study durations. Anyway, it could be in month as well, no problem. You can consider as a 2 months, no problem. But in addition to that, while in survival analysis or oncological research, what happened that one day or single day, you are not going to get the patients. So you have to conduct the study, and enter years, you are going to get 1 and 2 patient every day, or 1 and 2 patient in every week. So your recruitment is not going to complete in a 1 day or 1 month or even 1 year. So, but while you are talking about the sample size calculations or study design, then you have to have some consideration that what should be your recruitment period. Because if you think about a study should be 5 years, it does not mean that you continue the study or continue the recruitment for 5 years. It's not possible, because the patients joined your study or recruited at the end of 5 years. You have to give that patient also good amount of follow-up period. Otherwise, you are not going to get any, you can't expect any event for those patients. Okay. So if you're thinking your study is for 5 years, you have to wind up your recruitment period, let's say within 2 years or within 2.5 years. It's obviously depend on study to study, duration of the median survival of the study, and recruitment period, study site you are talking, prostate cancer, breast cancer could be varying differently from lung cancer and head and neck cancer. But that's a different story. But you have to have some rule about what time you are going to complete your recruitment. Once that the last recruitment is done, after that you have to give certain amount of period to complete the follow-up, because you have to give the last recruited patients to a good amount of time to be followed up. So that's why your inter duration of the study need to be specified into inter duration as by TAs and recruitment period by TR. So these are the another point. So once the questions came that what are the important material or point need to be considered by calculating the sample size, as I mentioned, alpha and power, but it is not the only one thing. There are other part, and these are all aligned with your study design, because we are talking about the oncological study design, prospective randomized control trial. So in that sense, these TAs and TR, all these notations comes together in addition to that lambda 1 and lambda 2, because we never get that opportunity to work with lambda 1 and lambda 2 or hazard rate if you talk about some observational study like incidence type of study. So it's only comes when you are talking about the survival or the oncological study. So lambda 1, lambda 2, it's done. Study duration also split into 2 parts as a TAs and TR. Now, sometimes we might happen that what you are anticipated loss to follow up, because you know that all patients are not going to be followed properly, because many of them are going to be lost during your study. So even if you give them good amount of time to be followed up for 5 years or 2 years even, still many of them are going to be lost. So what is your anticipated loss to follow up? Is it a 10%, 20%, 30%, more than that? So that percentage figure you can calculate based on your, based on your experience, based on your senior colleagues' experience, or some retrospective auditing the data, earlier data from your center. So that part need to be captured by eta value. That is, it could be, again, it can be maximum 100%. So nobody is going to be lost to 100%. So commonly we consider as a 10 to 20% value over here. This part now is this ingredient is called, we are talking about that side. It is a two-sided or one-sided. So if you are talking about the side, that's mean that you are expecting that lambda 2, that is the experimental arm, is always going to be the better hazard rate as compared to the existing arm. If you thinking that no, it might happen that experimental arm could be poor performer than existing arm, in that sense, it is allowing to consider the side as by considering by in place of 1, you can consider side as 2. So basically, if you say in other word, if you are not very much confident that your study experimental is strong or not strong, it could be poor performer or good performer, both. If you are in that dilemma, so in that sense, it is better to consider as a side is equal to 2. But if you are very much confident that anyway your experimental is not going to be poorer than your existing arm, it is definitely going to be better or at least similar performer with your existing arm. In that sense, you can consider sided as 1 rather than that. So that's all. Final that you mentioned about that alpha value, and if you consider that alpha as 0.025, 0.05, you can take point in place of 0.02, you can consider 0.1 as well. So as we keep on increasing your alpha value, your sample size is going to be lesser and lesser. That experiment we will do. So only this part is required. So only two line you have to need to write: library, GS design, and after that SS1, N survival, and this. And just to run these 2 lines, just put your crusher here, click on run, and line that, and thereafter you just call SS1 that we define it as. So see here, we are going to get so many results, so many things here. First of all, it's giving us in which, based on the literature, it's calculated the sample size. So based on the 1986 paper of Lachin and Flokes, that's the study based on the sample size calculation, they gave the derivation. Based on that, it is being done. Now, this is basically giving us study accrual period, study duration period, and study accrual period. So remember, so it's never say about it's a, what is the unit of this. It could be 2 months, it could be 2 years, but you have to be the unit should be unique enough for your study. So if you talk about two decades, no problem, pursue with the 2 decades. So corresponding to 2 decades, half decades, that's mean 5 years should be your accrual period. If you talk about the 2 years, corresponding to that, 6 months would be your accrual period. It says about the uniform accrual period. So are you going to take all patients within a 1 month, or 80 patients within 1 month and rest 20 patients in rest 5 months, or for entire 6 months you are going to get equal number of patients? Commonly, it is common phenomena that we always consider the equal amount of patients being recruited every month or every weeks. So that's why it is better to consider the uniform recruitment, unless and until some real phenomena like COVID kind of things happen. So we never consider as unequal, uniform distribution. So basically we consider the equal uniform accrual period. Now, as we mentioned that lambda 1 and lambda 2, these are basically converted into controls arms median durations and experimental arm median durations. And as we mentioned that what should be the censoring part over there, that is the how many are going to be lost to follow up from your study, even if you give them good number of study follow up, that going to calculate the censoring median durations or median time. So basically eta is used as we mentioned, as here in eta is 0.1, that's been converted into 6.9. So all this been done, and by default power is going to be considered here as a 90%. Type 1 is basically, as we mentioned, that alpha is equal to 0.025. This been considered to calculate the type 1 as 2.5%. Allocations, because are you going to get the equal number, randomly equal number of people that been divided into experimental or existing arm? So that allocation ratio is going to be 1:1 ratio. Eventually we can modify here if you want to have the 1:2 ratio or 1:1.2 ratio, that can be changed here. And finally we are going to get the required sample size as 430. And not only that, this product also give us the required number of event you need to get, that is 91. So what does it mean? Either if you are having 91 event before recruiting 430 patients, you can wind up your study. You can say, look, my study sample size was calculated with both the value with 430 individuals with 2 years study duration and half years accrual period, as well as 91 event. So if you it might happen that you are not in a position to continue to more recruitment because your study objective has changed, new drugs or new therapy regime has been introduced in the market, but still you want to continue your study rather than taking new patient, recruiting new patient in your study. In that sense, if you are having more than 91 patient at least recruited, so you can expect, or at least let's say 150 patients are recruited. So if you wait, because you don't have other way choice, because you are not in a position to recruit more patients for this study because market has changed. So in that sense, you can wait for, rather than 2 to 3 years, you can wait for more years, and let's see what happened. Those who were recruited earlier, how many were having raised with the event. If the events comes more than 91, you are very much okay to compile your study or round up your study, even you are not calculate or get your 430 patient sample means being collected. So this is the this is the way to get the sample size calculations with all remarks. Just I will change one point from here, and then after that I will sorry, I will take some question. So see, just example, just we say as alpha is 0.025. Now if I change from 0.25 to 0.05, that means I am increasing my type 1 error. Okay, so look here, type 1 error was 2.5%. So if I make that alpha is 0.05, my type 1 error is going to be more from 2.5 to 5%. My power is remains same, eta value remains same, lambda value remains same, lambda 1, lambda 2 value remains same, TS, TR, every values remain same. What only change is in terms of the sample size. Initially we were having 430, and now we come down to 352, only just shifting from 0.025 to 0.05. And simultaneously our event number also changed from 91 to 74. So this is the way. Now Dr. Vijay also mentioned that you have to look about the feasibility of a study. Sometimes what we understand that even if we say that 430 patients need to be recruited or 91 patients even need to be done, but in small center or very remote area, it's not always possible to get these number of patients, or it's need to having huge time investment. So in that sense, to try to make it much more feasible, we try to consider that reduce the power or reduce the alpha value from 0.05 to, let's say, even more. So now from only just from 0.05, I change it to 0.1. See, drastically now my sample size has been reduced from 352 to 272. It will keep on decline once you keep on increasing your type 1 error value. Simultaneously, you can chase your type 2 value as well. I think beta 1 will work, and beta, if you mention 0.8, I think it will show you beta value. Let's see, now beta is coming from earlier it was 90%. Now beta value is came only 20%. So see, now sample size has been reduced only 8, you know. But one thing is that nobody is going to, beta should be not 8, beta should be 0.2. So now from 90%, it came down to 80% power value. That is based on the beta value. Power value came down to from 90 to 80%. Alpha value remained 10%. Still from 180, it came down to 160, 86, where we are having where power was 90%, that was 272 with 57. So these are the all changes we can do. Not only the alpha and beta value, the assumption with lambda 1 and lambda 2 value we can make an attempt. As the difference between lambda 2 and lambda 1 is more, you are going to get less sample size. The difference between lambda 2 and lambda 1 is less, you are going to get the more sample size. Just one another example, I will not change alpha value and beta value, because ideally if I remain this earlier with this alpha 0.1 and beta as 0.1, then I'm supposed to get 272 and 57 even. But rather than 0.2 as lambda 1, let me put as 0.25 for lambda 1. Just I'm put 5 place more difference between. So now here the difference between lambda 1 and lambda 2 is 0.1, but here the difference is becoming 0.15. These things are unchanged. Let's see what happened. See, since I increase the distance between lambda 1 and lambda 2, sample size again reduced from 272 to 142. Eventually, if I decline that distance between them, 0.25 to 0.15, let's see what happened. So see, it increased rapidly from 142 to 902. Sample size become more now. So this is the way. This is a wonderful function, I would say, to calculate the sample size calculation as far as this oncological randomized control trial is concerned. So there are n number of design, n number of way to calculate the sample size, but every sample size calculations always rely on these alpha and beta value. This is the most important parameters. And in terms of the survival or oncological trial, lambda 1 and lambda 2 is another part. And study durations is third component that always need to be considered. And finally, the loss to follow up, the censoring part, that need to be kept in mind. So this is the way we do calculate the sample size and make the interpretation on that.
So any doubts up till now? So just for example, P0 was lambda 1, P1 was that lambda 2, plus alpha and beta were type 1 and type 2. Recruitment period and study duration he has shown you. Atanu, can you do one more? So I told you we'll talk about recruitment and follow once he shows you. So up till now you understood more the difference between the two arms, smaller the sample size, smaller difference, smaller. If you increase your alpha, increase means 5% goes to 2.5, again the sample size will increase. If you increase your power, that also will increase your sample size. Now let's say that I give the sample size to Manu Prasad where 10% has to be made to 15% with this, and it says 900 patient is not possible. Have a look at the number of events. It is 163. Atanu, can you change that study duration to 10 years and accrual duration to 8 years and just show what happens? You can now see that he has changed the study duration to 10 and the accrual duration to 5 years. Can you see that? Look at the number of events. It is nearly similar, 163, 161. But the sample size has gone drastically from 902 to 364. So remember, sample size actually is a connotation for number of events. You are not looking at the sample size. So you're actually looking at the number of events. And for number of events, means if you give the data time to get mature, you will get higher number of events. If you want the result faster, you require a large sample size. So we always tend to fluctuate among these two. We never try to fluctuate among these two. And when you can actually, and practically, it is not going to be possible for Manu to recruit the patient in 6 months and follow up in 2 months. It is always going to be like 5 years of recruitment and another 5 years of follow up, or 3 years of recruitment and 2 years of follow up. So looking at the feasibility, always play with this factors also of study duration and study. Atanu, can you show them one interim analysis command also so that they understand plan interim analysis?
Yeah, just before that, I would like to mention one thing. See, if you conduct any RCT in any other type of disease, like let's say you are talking about the diabetes, you're talking about the cholesterol control disease or skin disease, we never considers much about the study duration. The reason behind that, in those type of study, our outcome of interest is not the event as death. So outcome of interest for diabetes or other studies, skin disease or anything else except oncology study are that disease under control or not. Okay. So in that sense, we never comes with this scenario that if you increase the study durations, your sample size is going to change over and over. But in oncology, this is the unique scenario where our sample size unit, that is the patient, their number is changes over time because they are going to face the death over the time. So not only the study now individuals, along with their follow-up duration also important to be important here. That's why this unique scenario only raised in sample size calculation for oncological trial where event of interest is death or progressions. So that's why if you increase the study durations, your sample size is going to change. And again, this is the unique scenario happen only for this oncological studies, prospective oncological studies. Eventually, if you work with the, let's say we want to have the toxicity control or not, or that pain or that other stuffs are controlled or not among the patients. In that sense, you are not going to get this kind of study design where if you increase your study duration, your sample size will decline. Only the exceptional scenario in inter kind of study design, inter statistics applied everywhere, but only the unique scenario only occur here where you can expand your study duration and you can get less number of patients. Yes, so that is my point. So now you're expecting to have, let me have a look with the alpha spending function over there. Let me check where I put it. I think, yeah. And I put it. Yes.
There is one question.
One online question has come. Now we are speaking about RCT. Now the one question has come from Dr. Amol Patel that I wanted to analyze large genomic data.
Atana will take that question after the sample size example. How to analyze large genomic data?
Yes, we will see. So this is another functions available, in GS design as well. So just to run that, this function is applicable with the GSR function. GSR, this is useful, and where you are talking about lambda C. So basically, one group hazard ratio you are going to consider, and that is 0.2. with respect to the another group that is being considered 1. That's mean a reference group hazard ratio is considered 1. With respect to the reference group, this experimental group hazard ratio is considered 0.2. And hazard not hazard ratio, hazard rate. And another is the hazard ratio, hazard rate is 0.5 for the existing group. And again, the eta value is same with the censoring value, that is over 10%. Study duration, total study duration is considered as a T equals to 2, and minimum follow-up is considered as 1.5. So if I run this line, simple line, and thereafter, we are going to get the results. Let me plot this result. So this is some things given that with this alpha spending or the efficacy and futility studies value. So Dr. Bijay already mentioned that Z value and the P value, and with this boundary value, all this stuff. So look on that result. So if it says that if you are having sample size with 460, again with the 33% first interval, we can conduct, because once you are having 33% recruitment of 460 patient sample size, so 33% of 460 value, then we can perform the first interim analysis. Second interim analysis we can conduct when we are having 67% of 460 patients. Then we can conduct the second interim analysis, and final interim analysis we can conduct, or final analysis we can conduct when you are already having 460 patients, those are recruited. Now, corresponding to that, every interim analysis also supporting us, rather than having this 33%, we can also concentrate how many events are being done. So 33, 65, and 97. So if the 97 event, end of the 2 years been done, then we can conduct final analysis. After 1.3 years, 65 event occur, we can do the second interim analysis. And only after 8.8 years, let's say 8 or 9 months later, 33 event occur, then you can conduct the study. So these are basically giving us way when you can conduct the interim analysis. Corresponding to that, what should be the hazard ratio? What should be the efficacy value? What should be the Z value? What should be the P value? That is basically defined here. So if Dr. Bijay already mentioned that the triangle he has shown that. So once the P value is lying between these, then we are okay to pursue the study or to continue the study. If the P value, after having the first interim analysis, if your P value coming within 0.0013 to 0.59, after again second interim analysis, if your P value coming between 0.0054 to 1.17, okay, pursue the study. And finally, rely on the result 0.02 to 0.02. Look, here the P value is aligned from the lower and upper boundary is aligned below 0.05. But before that, for the second interim analysis and the first interim analysis, both the places, the boundary value, basically, this is called boundary value 0.0013 to 0.059. This is called boundary value 0.0054 to 0.17. In this boundary value, anyway, the lower boundary value is fine. It is below 0.05, but the upper boundary is big enough, good, high enough from 0.59, 0.17, and thereafter it lie down to 0.02. So as you see this nicely presented triangle, so see that the difference, the range difference between these boundary value is quite large initially in his graph as well, 0.0013 to 0.594. Slowly, this graph range values goes down, and simultaneously, see in the graphs, both the point has merged. The efficacy and futility graphs merge in one point. Here also the P value is 0.02 and P value 0.02, both point merge together. So that's the way. So here we have to have only one P value that need to be considered, that is 0.02. If your results coming below 0.02 with the P value 0.02, then you are going to accept the results that it is fine. And that's the way it should go. and others with the first and interim analysis are like that.
Just to
Over to you, Dr. Bijay, if you want to put any other comments.
So just to the Z values and corresponding P values we had talked about. So these are those values. And what he is trying to tell you, so as you go closer and closer to the final analysis, these two tend to merge together. So you could see that this is more 0.028, 0.0228. So are we clear on interim analysis? Any doubts on interim analysis or sample size calculation? Sure? Okay. Manu? Divya? Happy now? Okay. So we'll take the question of large genomic data. Atanu, so the question which has come from Dr. Amol Patel, and I think Dr. Amol Patel, is he online? Can you just check? Acha, he's from the viewing portal. Okay. So the question has come from Dr. Amol Patel is that how do you analyze large genomic data? And knowing Amol, I'm very sure the genomic data would be of gallbladder cancer. So let's say that you have a large 500, 600 genes panel, positive, negative, which has come, and you have outcome data. So how would you go about analyzing such large genomic data?
Yeah, so he shared with me his one Excel file, but I'm not sure how it would be good to open his Excel file here. So
data confidentiality, you
yes, so I'm not going to open it, just I'm discussing it that. See, it is a wonderful area to work with this oncological domain. We are having n number of genes and simultaneously having time to event data. This kind of data is called high dimensional data. What does it mean? The high dimensional data is that you are having, let's say, 300, 400 patient information, and this patient, their age, gender, their different staging status are mentioned. In addition to their duration of survival, like overall survival, progression-free survival, and their event like relapse, progressions, and death being defined as yes or no. In addition to that, there are a number of genomics expression, gene expressions. We worked earlier with this type of data that is 66,000 genes are there. I was looking in his data set. I think it was having nearly 300 genes expressions value, but we are having technology to work with this even it is 66,000 genes. So the fundamental question is that, or the clinical important question is that, out of these n number of genes, which genes are, or which genes expressions are relevant to be considered towards the disease progression or the death. Means if one gene expression is high, then does it means that this gene is going to penetrate the disease more? Or if this of that particular gene expression is low, does it mean that low expression is going to penetrate the disease and the person is going to relapse early or progress early or die early or not? That is the fundamental questions to address for this type of data. So one of the thing is that here it is not possible to proceed with these hypothesis driven methods. You can think that it's a quite contradictory statement, that just before that we mentioned that we should go with the hypothesis driven methods with the primary objective and calculate sample size and pursue the study. But since here we are having n number of genes, it is not permissible to frame n number of hypotheses. So since it is not permissible to have n number of hypotheses, but eventually since we are having n number of genes are also counted with equal number of patients. So earlier in cases, if you are having if you're forming different subgroups of substrata, then you are adjusting with the sample size, because different strata, several subgroups are having different sample size. But here, this is not the case. Here, what happened? Here, number of patients are equal. For equal number of patients, similar number of genes are there, and we are trying to identify which genes are relevant towards the disease progression. So here we have to rely on something called machine learning approach and something called variable selection methods. And these variable selection methods, mostly I'm trying to explain that these variable selections methods takes one by one gene, and by looping criteria, by automations criteria, it's try to find out the gene is relevant towards a disease progression or not. Once that is done, then it's throw it, and then it's take another gene, and it's again try to find out that second gene is relevant over there or not. Simultaneously, it's keep on take one by one genes, and it goes up to 66,000 genes. And out of the 66,000 genes, it's try to find out which genes are relevant, and what about the pathways analysis. That is called pathways analysis. Gene network formations are there. So that's the way it need to be considered. One remark that I have noticed, I'm not sure Dr. Amol is here or not. One thing is that in that data set, I have noticed the many places is being considered as a zero value. So if it is a zero value, then we commonly discard those expression value or those patients value. If you are putting this zero value as not expressed value and some value as expressed value, so basically you are going to make those genes value as yes or no formations, means dichotomize the value. That is okay, because EGFR also we make as a positive or negative. So that's fine, good enough. So to make the genes as a dichotomous formation, still the mechanism is initial mechanism is to pursue the variable selections methods in that aspect. So yeah, so there are in addition to the variable selection methods, there are classification mechanisms are there, and other stuffs are there. So just last week I submitted one of my next my book chapter with big data with oncology, and this book is going to be published from CRC Press. Once it comes, I'll be happy to share with you guys. So there I only dedicated with this high dimensional data and this in oncology, how to work with the high dimensional data and variable selection mechanisms, different way to finalize these relevant genes, and they should be control on the disease progressions. That's been there. So once it is done, I will share with you. But yeah, that is a completely different new techniques, new all way to go new directions, and that is completely different from the sample size calculation and clinical trial aspect as well.
Thank you, Atanu. Anyone has any other question? Any question anyone has? Okay, so Atanu, no more questions. And there was one question which has come online, which not for stats, but it's kind of a in general question has come from my friend Prashant Mehta. He wishes to know viable funding sources for investigator-initiated trials in India. Now, the thing is that whenever you write a trial, especially investigator-initiated trial, it's your headache to get the funding. So the best way is that you convince your institute to give some amount of seed funding. So that's called intramural funding. Tata gives that, so it makes our job very easy to do studies in TMH. The second source of funding is ICMR, ICRC. The third source of funding is something called SERB. It's SERB, you just Google SERB. SERB is a Scientific Energy Research Advisory Board, which also gives funding.
By DST.
DST gives funding. Apart from that, Wellcome Trust DBT actually gives a call every year in January for clinicians, which gives an early fellowship or internet fellowship or senior fellowship and a Margadarshi fellowship, which range from 1.7 crores going up to 7 crores. So you can apply for that. So these are the sources of funding. In addition, you can actually also take funding from pharma for your studies. For example, there are investigator initiated sponsored studies, which are like if you approach MNCs like BMS or MSDs or Pfizer or Sanofi, they have a program that if you are trying to work on their molecules, you can ask them whether they are running a such program 6 monthly at least once in a year. This program is open with MNCs where you can send your concept sheet to them, and if they most of the time it's a global competition, and if you get selected in that, Tata Group, our group has got twice or thrice such kind of fundings. If you get selected with that, they will completely fund your trial. Also, the drug, because you are going to use their drug, the drug will also come free of cost. Another source of funding is that you can actually try approaching NGOs and philanthropists for investigating shit. But this, I would suggest to approach after you build up your CV with a few studies, because that would require a lot more amount of convincing to be done. The next question is, in what situation DCGI clearance is not required? Basically, DCGI clearance is required if you are going to market the drug. If you're not going to market the drug, investigative studies, you don't actually require a DCGI clearance per se. But for pharma, it is a new drug or a new schedule or a new indication or new preparation, the DCGI clearance is required. Most of the times what is said is for investigator initiated studies, you need to notify the DCGI. DCGI actually gave it a 2 years pre-COVID. So that was 3 years back, has given a notification that the IEC, if feels that this investigative studies needs a DCGI clearance, they should notify the DCGI. Within 1 month, if the DCGI doesn't revert back, it is to be assumed that the DCGI has cleared your study and it's not required any go ahead. If DCGI puts a query, then you are liable to now answer the query, and to their satisfaction, they would either consider the DCGI study or not a DCGI study. It makes a lot of difference if it's a DCGI considered as a DCGI regulated study, which means that every essay and every event which happens in the study also needs to be notified to the DCGI. The last is how compensation clause is taken care with limited available funding. Now, frankly, compensation clause cannot be taken care by limited available funding. At Tata, what we do is that we have an insurance cover which covers for compensation for all studies which are investigated initiated. Those of you who are planning to do the study, I would request take an institute broad umbrella kind of insurance which will take care of compensation clause, because taking an insurance for every study in the name of a PI is not only not cost effective, it's also a headache also. Those were the questions online. Any other question is there? Just have a look. Okay. Thank you, Amul. Yeah. So with that, thank you, Atanu. I don't know if I didn't actually officially introduce Atanu. It's the end part of the discussion, but let me introduce Atanu. Atanu is actually a dear friend of mine. He's a PhD in statistics and is actually an authority in Bayesian statistics. He was in Tata for since up till last 6 months now. He has parted ways with Tata Memorial Hospital to do more bright things in future, and we wish him luck. Okay, and that's it. I am Vijay Patil. Most of you may be knowing me. If you don't know me, that is also okay. With that, we call it an end to the statistics workshop. If anyone has a question or was feeling shy to ask the question, you can ask the question now. So, okay. So what? Yeah. So, okay. So we have been getting a very good response to statistic workshop, and under the Cancer Research Statistic Foundation, under which the conference run, is actually a group mainly by young and budding medical oncologists like Manu, Ashay, and people, and they have been good enough to include academicians like us also. So under their guidance, we will be planning a statistics workshop, and that would have limited entry of only 10 to 15 candidates, and the financial aspect will be taken care by CRSF itself. So if any one of you are interested, we'll be sending the flyers in a few months from now. So see if you can attend, but that would be an extensive workshop only for 10 to 15 candidates with 1.5 or 2 days of grilling, so that you at least you get some hands-on with statistics, and that would be much theoretical. It would be more thing like practicals, like the way Atanu showed you the commands. Those commands will be given and you will be made to do the analysis. So if you are interested, those who are watching online also will be sending it to all people who registered for the meeting, and the things will be open on the CRSF website also. That's it. Any question? If anyone has changed its mind? No, then we'll call it a day, and most of you are invited for dinner, and Atanu can go and rest wherever he is. Thank you, Atanu.
Okay.
Bye.
Bye then. Thank you for all this effort, Dr. Vijay and Dr. Ashay. Have a nice dinner. Okay.
I make sure always I have a nice dinner.
Yes. Okay.